check, 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 check.
Check. Hey, 1, 2. Check. Test 1. Hey, check. Hey, hey. 1. Hey, check. 1, 2. Check. Hey, hey, hey. Check 1, 2. విను అట్లా కాదు బయటికి వెళ్ళి మొబైల్ కనెక్ట్ చేసుకో. Check test 1. Hey, check 1, 2. Hey, check. ఇట్లా పోతే అటు check 1. Hey, check test 1, 2. Hey, 1.
Yeah, now I can unmute. Okay, can you hear me? Hello? Hello? Can you hear me? Hello? Hello? Yeah, I'm actually speaking, but you are not able to hear? Okay, because I'm speaking, I'm saying hello, hello. Why it is not coming? Is it problem from my end? I have tested the. Mhm. Okay, okay.
Hello,
Hello?
Sapni sir.
Can you speak once now, sir?
Hello, can you hear me?
Yes.
Okay, okay, then it is
I
fine.
can hear you from here.
Sir, can you hear me?
Yes, I can hear you very well.
Okay.
ठीक है.
So now everything is set.
Z. Right. Keshav sir. 9. 9. A very good morning to all the viewers and all the faculty and delegates gathered at Leadership Academy of Reddy's Lab. I welcome you all to this third YOU conclave. I now call upon Dr. Zishan Hamid, Chairman YOU, to address the gathering.
Thank you, Dr. Abhishek. Dear elders, board members of YOU, and my dear friends, I extend a warm welcome to you all, and I hope that you all are doing well. As you all are aware that the youth wing of USI was inducted in December 2019, and I must thank the previous council members under the leadership of Dr. Madhu Agarwal sir, Dr. Rajiv sir, and Dr. Anand sir for supporting this noble cause. And the legacy has continued immensely under the support shown to us by Dr. Mallikarjun sir, Dr. Keshavamurthy sir, and Dr. Sabnis sir. The youth wing was created with an intention of providing a platform for youngsters so that they get an opportunity to participate in the academic sessions. But over a period of time, it has elevated and evolved and grown to understand the youth better, be it their grievances, job preferences, career opportunities, or guidance, or the research opportunities. We were fortunate to have a session for the youth at USICON Kochi 2020. Since then, all our plans were restricted as COVID situation hit not just us, but the entire world. As a healthcare workers, many of us were at the front line, and you were very proud of all the members and with regards to their contributions in fighting this deadly phase. And also I extend the condolences for those who have lost their family members in fighting this deadly pandemic, illness during the pandemic. During the COVID era, we were restricted to having a first and second virtual youth conference presided over by our past chairman, Dr. Dilip Mishra, and his team of council members who made it a huge success. Since then, we were having regular meetings over the online platform and worked relentlessly to serve the USI under the leadership of Dr. Keshavamurthy sir and Dr. Sabnis sir. There has been a change in the YOU with the induction of new office bearers representing all the different zones of USI. We have Dr. Karthikeyan and Dr. Zaid from the South Zone, Dr. Abhishek, Dr. Abhijit and Dr. Ravijan from the West, Dr. Aditya Sharma and Dr. Milap from the North Zone, and Dr. Devang Sharma and Somarinder from the East Zone. As I welcome all the new members of the YOU, I must not forget the contributions of the past council members. We are fortunate this time to conduct the Youth Conclave in Hyderabad at Dr. Reddy's laboratory, and the team of Dr. Reddy's lab have put in all their efforts for today's program, and so is the central office team to make this program a success. We're looking forward to meeting you all, everyone in person, and I'm happy to see that there are so many of you who have shown a lot of love and support towards the YOU and helped us in making this program a reality. I'm sure that we'll all will be benefited from this program and have the memories from Hyderabad to cherish. Welcome you all. Now, may I request Dr. Keshamurthy sir and all the YOU council members to come on stage for lighting of lamp.
May the divine light of knowledge come to us from all directions. On that note, I call upon Keshav Murthy sir, Honorary Secretary USI, to address the gathering.
Good morning, everybody. President of the Urological Society of India, Dr. Ravindra Sabnis, is connected virtually. And my dear friends, seniors, and colleagues, it's a pleasure to welcome all of you to this third Youth Conclave at the Reddy's Leadership Academy in Hyderabad. This program for the last 2 years was on a virtual mode after the one in Kochi. And I must congratulate the team of the new team of you, which have carved a fantastic scientific program for this Youth Conclave. And I'm sure all of them would benefit with this scientific program. We have actually opened this also for the virtual platform for people who are unable to join us here. The Urological Society of India thought of creating this youth organization within the USI is to encourage, because we find USI growing by leaps and bounds now. You have close to 300 to 400 people who will get added, and all of them are young members of USI. Like India, which is young, even the USI is quite young now. You have majority of the people who are quite young, less than 45 years of age. And to be exact, I think there are 1,340 people who are less than 45 years of age and who will form the U organization now. I would call upon the organization not only to organize scientific meetings like this, but it was basically designed to see into the needs of the youth who are inducted into the Urological Society of India. So I would urge you to go into what is the needs of them, may it be fellowships, residencies, what are the grievances which they have, how do they start their practice, helping them to start their practices. All these things needs to be looked into. I'm sure the leadership of the YOU would be doing this. And with this, I would wish you all the best for this youth conclave, and thank you.
Thank you very much, sir. Indeed, it has been a wonderful journey working with you. And I must put this on record that the ease of communicating to USI for this organization has been absolutely smooth as far as the functioning of the organization is concerned. Now I call upon Honorable President, Urological Society of India, Professor Ravindra Sabnis, sir, to address the gathering. Sir, good morning.
Kindly unmute, sir.
Sir, sir, you're muted.
Can you hear me now?
Yes, sir, we can hear you.
Okay. All right. So good morning to everyone. The chairman of YOU, Dr. Jishan, the Honorary Secretary USI, Dr. Keshav, and all the young members of Urological Society of India. Well, at the outset, I would like to apologize that I'm not there in person because I'm just recovering from the enteric fever. But I can understand, I can imagine the kind of enthusiasm, kind of energy which must be flowing across the auditorium when all the young, talented people are gathered together. Well, as Keshav rightly pointed out, that how do you understand or how do you judge the future of any organization? Whether it is an organization of the medical organization, or even whether it is a hospital, whether it is a social organization, or whether it is state or the country. The future depends on what is the young, talented pool of the people. So it is a number of young people which actually decide what is the future of that particular organization, or for that matter, the whole country. As Keshav said that ours is the youngest country, and maybe another 15, 20 years, we will be the only country which will provide the whole workforce to the whole world. So the whole world is going to look at you after 15, 20 years. So that is the kind of future what we are going to have. And that is all because of the young people of India today. Well, as Keshav also said, that USI is same as what is happening in India. We have the young people who are outnumbered than the others. The number of people who qualify for the U are much more. And it is going to increase because every year we are going to add 300 young people to our society. And therefore, pool of younger people is going to increase. And therefore, say 15, 20 years down the line, when USI is going to become much, much bigger, the younger talented pool of people in USI will be much, much bigger. And that's why I have no doubt that 15 years, 20 years down the line, when majority of you will be at the peak of your career, that time the whole world is going to look at USI, and majority of the things will come from USI. Everybody, even I know, even the scenario today, that there are majority of the associations are ready to tie up with us. Somehow they want to get tied up with us simply because we have a future. And that future depends on you. If the younger people of USI are channelized properly, USI is going to be the body which will control the whole world. But the most important thing is that these young people should be channelized properly. And how do we channelize them? Channelize them means you have to give them the opportunity. And this formation of a youth wing is the one step ahead in that direction. USI has identified that younger people are the most important people from the organization point of view. And therefore, you must have seen that right from you enter the training of urology, whether it's MCH or DNB, we do a lot of programs. There is no other association in the whole country which does programs which are of that quality for the residents, for the trainee people. And now we want to extend that after passing out, that under the banner of the U of USI, the youth wing of USI. So it is important for you to understand what is the need of the young people. It may be academic, and as Keshav said, it could be non-academic, but it is for you people to understand, and it is for you people to discuss it out. It is for you people to provide the solution to the younger people, younger than you, because you have experienced all that. And that is what is the important of the U organization. And that is how more and more people will get attracted and more people will get benefited with this organization. As I said, that U is the growing body. And it is not only that we look at you, at what programs you are doing, how many programs you are doing, what type of program you are doing. But from the USI point of view, let me clarify that the other objective of formation of this U is to identify the future talent. Tomorrow's orators, tomorrow's speakers are going to be from you. Tomorrow's presidents, tomorrow's secretaries, tomorrow's so many people, they are all going to come from you. And therefore, it is for you people to make use of this platform. Our objective and our motive is to give you a platform. We have given this platform of you, where everything is managed by you. You decide the speakers, you plan out the program, you execute it, and you involve your own people. So we are going to provide you the platform. Now it is up to you to use that platform and shine. Once you shine, and when you people come together and shine together, that is what actually USI wants. And that is how the future of USI will get ensured. Well, with this word, I must congratulate Dr. Zishan and his team for charting out the fantastic program. I've gone through the program. Unfortunately, I'm not there. I'm missing out a lot of fun. But in any case, I must congratulate you for the fantastic program and wish you a great success for next 1.5 days. And I'm sure this is going to be a great event which is going to happen in physical mode. Last 2 conclaves were virtual, but this is a physical mode which is going to give a complete turnaround. So with this word, I must thank the organization for giving me this opportunity and wish you a great success. Thank you very much.
Sir, thank you very much for enlightening us, and we wish you a speedy recovery. With that, we start the proceedings for the day. The first program for the day is a course meant for or focused at training people on laparoscopic pyeloplasties. To moderate this course, I call upon Mallikarjun Reddy sir and Dr. Praveen Kumar and Professor S.K. Singh sir. So this course is spread over 2 hours and would be encompassing all the aspects of a laparoscopic or a minimally invasive pyeloplasty. To set the ball rolling, I invite Dr. Abhish Hegde.
Good morning, everybody. I'm Dr. Abhish Hegde from Topiwala Medical College, Mumbai, and I'm here to talk about the indications for minimally invasive pyeloplasty, when to and when not to. So this is the outline of my talk. That is, So I'll be talking about the indications and contraindications. Also, note on pediatric pyeloplasty, the approach, a few approaches that we have for pyeloplasties along with the less commonly used approaches. Coming to the indications, the traditional indications are progressive loss of renal function as evidenced by a drainage time, a T-half of more than 20 minutes, or a split function less than 40% for the obstructed kidney on a DTPA renogram, a greater than 10% difference in the split renal function along with symptoms or the presence of obstruction, presence of infection or secondary calculus formation, worsening hydronephrosis or parenchymal thinning, a type 2 O'Reilly curve in the isotope renogram, symptomatic cases with equivocal T-half, that is between 10 and 20 minutes, but with worsening kidney function is also an indication for pyeloplasty. The contraindications today, as we have grown with the use of laparoscopic and robotic pyeloplasties, remain those that are only for traditional laparoscopic contraindications, that is active urinary infection, uncontrolled bleeding disorder, or poor pulmonary function. The older days, the relative contraindications used to be intrarenal pelvis or gross hydronephrosis. All of those, and even ureterochelicostomies, all of those are successfully being done today, as we will be seeing during the course today. What are the different approaches that we have, and when do we use them? Laparoscopic pyeloplasty has today established itself as a standard of care. It is most ideal for failed previous endopylotomies, very proximal ureteric strictures which are more than 1 centimeter in length, the presence specifically of a crossing vessel or ectopic kidneys such as pelvic or cross-fused ectopia, and horseshoe kidneys. The transperitoneal pyeloplasty has the advantages of being familiar with two urologists with the operative field, the larger space for working of the laparoscopic instruments, and it is good to deal with the horseshoe kidney. The transmesocolic route specifically can be used in thin or pediatric patients for the left side. The retroperitoneal approach is ideal for patients who have had multiple prior abdominal surgeries. It has the advantages that there is direct access to the renal pelvis, no need for colonic reflection, avoids urinary leak into the peritoneal cavity, and hence hastens recovery. There is a lower risk of bowel injury and could be prudently used in obese patients. The disadvantages, however, are that we are not familiar with such kind of retroperitoneal approach, smaller working space, and finding the crossing vessel could be challenging a lot of times. Antegrade stent placement is difficult in this approach. However, it can be circumvented by the use of a flexible ureteroscope. Contraindications are, especially in pediatric patients, are the weight less than 6 kilograms and prior retroperitoneal surgery or percutaneous nephrostomy placement. Coming to the growing approach today, that is robotic assisted laparoscopic pyeloplasty. It is particularly useful because of the lower learning curve for achieving operative competency, ureterochelicostomies for redo surgeries, or it could be as a primary modality for extreme cases of intrarenal collecting systems. The contraindications are a small intrarenal pelvis and infants who are less than 6 kilograms in weight. Multiple prior abdominal surgeries are also a relative contraindication. Coming to endopylotomy, which was touted initially as the most cost-effective and having the least side effects. However, with the approach of laparoscopic pyeloplasty and with the experience that we have today, this is no longer true. Cost advantage might still hold good. It is especially useful for secondary PUJO or failed pyeloplasties. Stenosis length of the ureter, which is less than 2 centimeter. Without any significant hydronephrosis, a renal function which is greater than 25%, PUJO patients who have concomitant stone disease, and it is to be remembered that this approach is to be used when there is no high incision of the ureter or there is no crossing vessel or failed endopylotomies previously. Endopyloplasty is a historic approach today. Initially was supposed to have similar outcomes with a laparoscopic dismembered pyeloplasty. Coming to pediatric pyeloplasty, a few points about this. With the experience that we've had with pediatric pyeloplasties, laparoscopic pyeloplasty is today feasible in even patients who are less than 6 months of age. Robotic platform is safe for patients between even 3 to 12 months, provided the weight is more than 6 kilograms. Redo cases are feasible, and to be kept in mind is that with increasing anteroposterior renal pelvic diameters, the outcome is poor. A few less common approaches in pyeloplasty. The laparoendoscopic single-site surgery. This was supposed to have the highest patient satisfaction primarily because of the cosmetic reason. A few approaches specifically for learners could be the hybrid LESS, that is, which has a shorter learning curve. This is because we use the LESS approach to dissect, but however, the anastomosis is done extracorporeally. The one trocar assisted pyeloplasty is a retroperitoneal approach through a 12 mm incision, wherein we put in a single camera port and a single trocar for dissection. And again, we bring out the anastomosis is carried out extracorporeally. With growing experience today, the use of BMG onlay graft has come into picture for pyeloplasties, both for robotic as well as laparoscopic approaches, and could be useful in treating recurrent UPJOs or long segment strictures. Chronic stent drainage could be an approach for patients who refuse other sorts of treatment or who are not candidates for other procedures because of contraindications mentioned previously. We choose to observe patients if they're symptom-free and have good parenchymal function and good functioning, and as well as preservation of the renal parenchyma. This also could be a prudent approach for patients who have been incidentally detected with hydronephrosis or PUJ obstruction. However, the need for follow-up in such patients has to be stressed. Not to forget our basics, open pyeloplasty is to be done when we don't have the resources or the surgeon's experience is limited. Here we have a chart that is comparing all the different approaches through minimally invasive route. However attractive the robotic surgery might seem, we can note that with increasing experience, we can circumvent all the disadvantages and bring down the cost for our patients with laparoscopic pyeloplasty. I thank the organizers for this opportunity. Thank you.
Thank you, Dr. Abhish. I think we will set the ball rolling with the next two more topics, because these are the ones which will give us the base for further discussion. So may I call upon Dr. Shashank Agarwal for back to basics, anatomy pertinent to the minimally invasive pyeloplasty.
Good morning, chairpersons and delegates. Welcome. Good morning. Greetings from Lucknow. I, Dr. Shashank Agrawal, and I am going to talk on anatomy pertinent to minimal invasive pyeloplasty. So the importance of the anatomy is to define the goal of precision medicine, where the lesion is accurately removed, causing reduced disturbance to the adjacent healthy tissues and hence minimizing the surgical complications. So in this talk, I will be looking for the anatomical factors, the intra as well as extra renal pelvis, the anatomy of the crossing vessels, ureter anatomy, different types of pyeloplasties, few words on the pyeloplasties in anomalous kidneys, and few words on the latest technology as well. So before contemplating for the anatomical factors for the operating surgeons who are contemplating for robotic or laparoscopic pyeloplasty, we have to look for the renal pelvis size, the degree of hydronephrosis, the presence or absence of the crossing vessels, the level of the obstructions, the presence of anomalies or stones. So in the patients having extrarenal pelvis, the dismembered laparoscopic pyeloplasty is more suitable because the pelvis get easily exposed after the medial mobilization of the colon, and there is also adequate pelvic tissue for reconstruction after the excision of the pathological segment. In the patients with intrarenal pelvis, following challenges can be encountered during laparoscopic pyeloplasty, that is difficult access to UPJ. The dissection starts from the proximal ureter, unlike the conventional pyeloplasty in which the dissection starts from the pelvis. Lower pole of the kidney may needs mobilization. There may be the need for insertion of the fourth pole for lifting up of the kidney in an upright position. And these sort of patients may need extensive ureteral mobilization. And in these patients, it is difficult to put the His suture due to limited pelvis. Crossing vessels, they are encountered in approximately 30 to 70% cases of the UPJ, and they usually arises from the aorta or from its branches. And it can be a sole extrinsic cause for the UPJO or may coexist with the intrinsic cause as well. And these vessels pose a threat of hemorrhage during minimal invasive therapies. So as per the intraoperative classification of the anatomical relationship between the lower pole crossing vessels and UPJ given by the Snyder et al., there are three types. In type 1, the vessels run in front of the dilated pelvis and hence doesn't cause the obstruction, while in type 2, the vessels run in front of the UPJ and hence frequently associated with the obstruction, while in type 3, the vessels run beneath the UPJ, hence causing ureteral kinking and subsequent obstruction. There is a definite role of preoperative retrograde pyelogram for identifying the precise position of the UPJ, which will help in the placement of the incision, and it also rules out some sort of concomitant distal obstruction, as we can see in the second picture that apart from the kinking at the level of the UPJ, there is also narrowing in the distal 1/3 of the ureter. There is also a definite role for on-table ultrasonography, especially in the kinds of pediatric patients where no preoperative anatomical imaging is being done. So after placing the patient in the final position on the operating table, an on-table ultrasound has to be done for delineating the level of the UPJ, and subsequent port placement are being placed, keeping in mind that the camera port should be at the level of the UPJ. Coming to the anatomy of the ureter derives its blood supply from the renal artery, aorta, and the gonadal artery, and all these vessels approach the ureter from the medial side, and they course longitudinally within the adventitia layer. So during laparoscopic or robotic pyeloplasty, the peripelvic or periureteric adventitia should not be stripped off from the pelvis or ureter respectively in order to maintain the vascular supply. And as these vessels approach from the medial side, the spatulation of the ureter should be done on the dead lateral aspect of the. Coming to the different types of pyeloplasty, dismembered pyeloplasty should not be considered in the patients with lengthy strictures, small intrarenal pelvis. Anatomical factors contributing to choose different type of pyeloplasty. Foley's VY pyeloplasty should not be done, should be considered in the patients with high ureteric insertions or small intrarenal pelvis. And the flap pyeloplasty should be considered in the patients with large accessible extrarenal pelvis or with a long segment of the ureteric narrowing. Now, a few words on the anatomy of the UPJ in anomalous kidneys. In patients with horseshoe kidney, the renal vessels have abnormal relationship to the renal pelvis and ureters, and also abnormal blood supply to the isthmus. And usually the ureter crosses anterior surface of the isthmus in this cohort of patients and may get easily compressed by the aberrant vessels. So a preoperative 3D scan, CT scan is important for locating the calycial orientation in the malrotated kidneys, as well as to appreciate the aberrant vascular relationship, especially at the lower pole as well as at the level of isthmus. So unlike the standard port position for laparoscopic pyeloplasty, the ports in horseshoe kidney patients are usually placed 5 centimeters more caudal due to low lying position of the horseshoe kidneys. And a preoperative CT angiogram can accurately delineate the vasculature of the collecting system, where the vessels are mostly ventromedially related. In the patients with ectopic kidney with UPJO, following challenges can be encountered by the operating surgeons, like deep location of these kind of ectopic kidney with abnormal rotation or abnormal vascularization of the ectopic kidney. And there can be difficulty in identification of the dependent portion on these ectopic environment due to renal malrotation. And the best exposure for these ectopic kidneys for UPJ repair can be easily achieved with the help of a transperitoneal approach. So as the fetal kidneys ascend upward during the course of development, initially the hilum, which was facing anteriorly, rotates and finally turns into the medial directions. And with ascent, the vascularity pattern of the kidney also changes. So at the final level, the level of the ectopic kidney and the level of its artery and vein origins should be similar one. As Abhish told, the transmesocolonic approach is possible, particularly in the thinner or younger patients with less tissue in the mesocolon, where the dilated pelvis can be easily visualized. Coming to the UPJO in the duplex moiety system, a preoperative CT urogram or IVP should be done to understand the anatomy as well as to decide the best surgical approach. In the patients with incomplete collecting system, we have to assess the length of the ureter between the UPJ as well as junction of the upper and lower port moiety. And if the ureter is of sufficient length, we have to go for a standard dismembered pyeloplasty. And in case of compromised ureteric length, we can think for pyloureterostomy. So pyeloplasty in malrotated kidneys, the challenges which can be faced by the operating surgeon is the different anatomical location, and there may be need for auxiliary surgical procedure like mobilization of the kidney or re-rotation of the pelvis. As here we can see in this video that initially for left side UPJO, a transmesocolonic approach was attempted but failed because the pelvis couldn't be identified. So on the laterocolic approach, after mobilization of the colon, we can appreciate the kidney was malrotated with the renal parenchyma was facing upward. And on further dissection, we can found that the pelvis was facing posteriorly with the hilar vessels were running in the cranial directions. So this is the latest technology, which stands for the 3D dimensional image reconstruction technology based on the high resolution CT in pyeloplasty, where we can appreciate the relationship between the obstruction of the UPJ as well as blood vessels in a 3D configurations, where specific organs, blood vessels, or tissues can be arbitrarily split, combined, or hidden. And hence this provides the operating surgeon a greater perceptual understanding of the operating content. Thank you for your patience listening.
Yeah, thank you, Shashank. Yeah, I think no, we will do, Abhishek, because these are basics of pyeloplasty. When we come to the procedure of pyeloplasty, these would be also be discussed. So may I call upon Dr. Suyog Shetty to speak on the radiology of PUJO.
It's not on. That's next. Good morning. My name is Dr. Suyog Shetty. So the topic I'll be speaking about is radiology of PUJ obstruction, how it impacts a novice. So the idea behind this talk is not to enumerate all the radiological investigations that we have or how they are done or how they are interpreted, because all of us know that. It is just a refresher of how these can be helpful to diagnose the condition properly so that we operate when indicated and don't end up having surprises on table, which can be a big problem if you are a novice, if you're in the initial days of your career learning minimal access surgery, especially for PUJ obstruction. Because the problem is not all kidneys deteriorate. Even if there is obstruction, you have to have the right indication, a kidney that is symptomatic or deteriorating to be posted for surgery. No test is infallible. Every test has its own strong points as well as pitfalls, which you should know. And there are other conditions which can masquerade as a PUJ obstruction. So you should be sure of your diagnosis before you go ahead and operate. And also the coexisting problems which can complicate your surgery. So these are the problems, common problems that can be misdiagnosed as PUJ, non-obstructive causes like reflux, megaureter, multicystic dysplastic kidney, or a parapelvic cyst, secondary PUJO, duplications, ureteroceles, etc. Also, we should be aware of secondary stones, which if missed can cause problems later on, or an ectopic or a malrotated kidney, or a very large pelvis which needs reduction, which can increase the complexity of the surgery, a crossing vessel, duplex systems, or an absent opposite kidney where, of course, this surgery becomes even more important. So these are the investigations, as we all know, that we have, which we can do before we go ahead with our planned procedure. An ultrasound, IVU, CT urogram, renal scintigraphy, or MR. IVU, the age-old investigation, still relevant, but the problem is that it's not ideal as a sole investigation to plan your surgery. The bowel prep is cumbersome for the patient. Vascular anatomies, radiolucent stones, difficult to assess the cortical thickness that is available in that kidney to decide whether it's a salvageable kidney or not. Anatomical abnormalities may be difficult to interpret, which can result in some intraoperative surprises. But the major reason why this has the use of IVU has gone down is because it has no major advantage over a CT urogram. So if required, what has to be done is a well-tempered or a tailored urogram, where we get a proper bowel preparation and do get a scout film, then 5, 10, 15, and 20, 30 minutes. But at 15 minutes, say you don't get contrast in the calyces, then we use what is called as a rule of 8, where you get the next film at 2 hours and so on and so forth. So you try to answer the question that you set out to answer using the investigation. Or, for example, if you have a picture like this at 5 minutes, you need not proceed with the study any further. The other thing is use of diuretics. Even in an IVP, a diuretic will help you diagnose equivocal cases. For example, in this case, where on the right side it was doubtful, but post diuretic, the obstruction is very well evident. Similarly, some more pictures of where diuretics can be of help. Though IVU, all said and done, we can still diagnose a lot of problems on an IVU if you are keen enough to look at it. For example, a retrocable ureter or a crossing vessel, which appears as a radiolucent band between the ureter and the dilated pelvis, or secondary stones, which might appear as, which will appear as filling defects. Even an extrarenal pelvis, for that matter, can easily be diagnosed on an IVP if we put in the effort and time to go through it. Or a ball pyelogram, which is suggestive of a very grossly dilated system with probably a severely decreased function or malrotated kidneys. A CT urogram, of course, is the investigation modality of choice, especially to plan our surgery, because you can rule out most of the differential diagnosis or the secondary problems that might coexist with PUJ obstruction. We can also assess the pelvic volume as well as the available functional parenchyma on that side. The only problems, if you have to enumerate them, are, of course, the radiation exposure, need of anesthesia, especially in younger patients, and if there is a compromised function where you can't give iodine-based contrasts. As you can see, like a crossing vessel or a parapelvic cyst, which might have been misdiagnosed on an ultrasound, can easily be picked up with a CT urogram. Renal scintigraphy, very useful, of course. The best agent that we can use are MAC3 or EC. Of course, MAC3 not being available, EC is the preferred agent because compared to DTPA, it has a much higher renal excretion efficiency. So it gives a much sharper image and also more accurate. And of course, scintigraphy has very low radiation exposure. As you can see, the first image is EC, which has a much sharper image than a DTPA produced image. But the pitfalls with scintigraphy are, of course, hydration status and the bladder status can affect the results, patient positioning, the use of radiopharmaceutical, as I said, between say DTPA and EC, there is a difference. Region of interest has to be marked. So this becomes a major operator dependent factor while interpreting this, the result of renal scintigraphy. Poor renal function might interfere with the diuretic function. So that has to be kept in mind. So here again, what is required is a well-tempered renogram where a requisition form saying that query PUGO is not good enough. You have to tell your radiologist as to what the ultrasound finding is. Is the pelvis grossly dilated? What is the creatinine level, so that he can decide on how much diuretic has to be given. And while assessing, we don't look at any one final diagnosis or anything. We have to consider all three things, and that is the images or the pictures that are available, the graphical representation, as well as the numerical values to come at the final diagnosis. Diuretic opinions vary. There are multiple protocols, but F0, that is diuretic being given with the radiopharmaceutical, is the most convenient, as well as it gives acceptable results. What has to be kept in mind is the dosing of the diuretic. 40 milligram for an adult is standard, but in pediatric age groups or with compromised renal function, you have to up the dose so that you get adequate diuretic action. As you can see, this is the pre-diuretic phase, a typical type 3A curve, where after giving the diuretic, the kidney just fades away. So diuretic can help you lessen the number of equivocal results. Bladder catheterization, again, not always necessary, but in specific cases where especially children who might start wriggling around because their bladder gets full towards the end of the investigation. In such patients or patients with a small capacity bladder, reflux, hydroureter, or posterior valves. So these are conditions where catheterization should be considered. As you can see in this study here, the diuretic was given, though the kidney is decreasing in intensity, but it still persists. The same thing with a catheter, you realize that it was more because of the bladder being full than the kidney being obstructed.
So you'll have to push through, boss.
Sorry?
You have to time.
Oh, sorry, sir. So equivocal cases, in spite of everything, 10 to 15% end up being equivocal. So following all the standard procedures, you can reduce the number of equivocal cases. So can we skip a urogram? The recent modality which can help you do that is gadolinium DTPA MRU, which gives you both functional as well as static imaging. and assessment of the available volume and functional parenchyma. Here, transit time more than 8 minutes is considered obstructed. This has been tested against DTPI and has been found to be reliable. Ultrasound, the thing that I would like to point out is resistive index. Again, equivocal cases, checking the resistive index, which cutoff taken as more than 0.7 or a difference of more than 0.1 is considered
We'll have to conclude,
significant.
boss. We are
Yes, sir.
beyond,
To conclude.
way beyond time.
Yes, sir. To conclude, you have to plan ahead, get your investigations in order, and look for all the differentials before you plan to cut. Thank you.
Thank you, Suyog. I invite Dr. Naveed Khan onto the dais. Naveed.
I think the first three talks will take a little discussion. We'll have about 2-3 minutes of discussion if there is anything. All three, both Abhish, Shashank, and Shyog. But Shyog, I think I have one point to make against one of your statements, which you said that the CT would give you the functional part of the kidney and the functional parenchyma. I beg to differ from you because CT, it is very difficult to actually look at a function, evaluate a function of the kidney. So the parenchyma, it wouldn't be, there are softwares which you have, then only it will give you, but not on a routine basis. Okay. So any other questions someone would like to ask on the basics so that we can have one of the three experts speaking on that? Okay, looks like that everyone's strong in the basics. So
I invite Dr. Suraj to present on his talk on port placement and ergonomic considerations.
I would like to thank the USI for giving me this opportunity today. We'll be discussing about the port. How do we move forward? Okay, sorry. So we'll be talking about port placement and ergonomic considerations for a novice in pyeloplasty. Ergonomics is the applied science of increasing the efficiency in a working environment with safety. The target today would be to discuss about the ergonomics of the OR organization, the positioning of the patient, the physics of laparoscopy, and the ideal port position. The changes in laparoscopy are that there's a change in the surgeon's position, change in the operative field, there's an inversion of fulcrum effect, there's a reduction in the tactile sensations, long instruments with restricted articulation in laparoscopy, and the port placement strategy is very important. We will discuss about the OT assembly, endocard position, table specifics, anesthesia unit. Now, the ideal setup is that the surgeon should operate from the abdominal side of the patient, and the first assistant is usually caudal. The laparoscopic cart is positioned at the back of the patient's chest with the operative team facing the video monitor. The assistant is positioned at a different level than the surgeon to prevent conflict of the laparoscopic instruments. The cart should be ideally at least 4.5 feet from the ground. The distance between the screen and the person operating should be at least 1.6 times the diagonal length of the screen. This is important because nowadays we have large screens in the OT also, so it should not be very close. We should have a good anesthesia station. We should have EtCO2 monitoring. If the EtCO2 levels may go up, then we may need to stop for some time in the middle. A good table is a prerequisite. Now, the ideal posture, ergonomically speaking, is that the head should be straight with extension of the cervical spine. We should have relaxed shoulders. The elbows should be in 70 to 90 degrees angulation. The forearm should be along the long axis of the instruments, and the center of the monitor should be at least 20 degrees below the eye level. This is because this is the physiological position of the oculomotor muscles. The most important part of surgery is to position the patient correctly. The patient is initially positioned supine for IV access, intubation, general anesthesia. A nasogastric tube and Foley's catheter are also placed. The umbilicus is usually over the break of the operating table. The patient is in modified lateral decubitus for the right side and a strict lateral decubitus for the left side. The table can be flexed or a pack is positioned under the patient at the level of the umbilicus. A padding is, we have to support the buttocks, the dorsum and the axilla. This is particularly important to prevent brachial plexus injuries. The patient is held in position with strips of cloth. Now, whenever we insert the instrument through a pot, we have to think of it like a lever. So once a laparoscopic instrument passes through the pot, the whole system behaves like a lever. So the D1 W1 is equal to D2 W2. So if the distance is not correct, the effort will be too much or too less. The surgeon's movements should, ideally the surgeon's movements should be precise and controlled. The force applied by the surgeon should work to his advantage and the target should not overshoot. Now for surgery, ideally we should have around 50 to 60% of the instrument inside the patient. If we have around 50% for every one in effort, you would get one in result. Not good is overshooting. If we overshoot, then even fine movements outside the patient will result in large movements inside the patient. And if we undershoot, that is demultiplication, we will need large movements for small effects inside the patient. So the pot placement in that should be very important. The spots should be placed as that they are at an optimal distance from the pathology and the instrument is at least half to 2/3 inside the body. Now, the pot geometry depends on the patient's profile, whether it is deflatable, how big is the PUJ, obesity. If the patient is obese, we need to consider the panels falling downwards and we need to position the pots more laterally. Now, the axis of work should always be in a straight line between the surgeon, the pathology, and the monitor. In laparoscopy, that is important. The law of triangulation is important for pots. We should have 6 to 8 centimeters between the working pots and 10 to 15 centimeters between the pots and the target organ. If we don't use the ruler, so 4 fingers between between pots minimum. And if you use a triangle with a camera in the middle, four fingers between the camera and the pots and 5 fingers between the 2 working pots. The manipulation angle should, like how we cut meat, it is always in the direction of fibers. So even your surgery, it has to be in the direction of the pathology. If the pots cause too much elevation, we will get shoulder pain. So the elevation angle should also be monitored. Now, while placing the pots, we should have an idea about the inferior epigastric artery anatomy in order to avoid that injury. Now, for insufflation, usually a Veress needle can be used. It is disposable or reusable. The blunt tip retracts. And when it passes through tough structures, exposing the sharp edge, you will hear 2 clicks when you pass. One is through the rectus or the rectus aponeurosis. The second will be when you are passing through the transversalis fascia. You will hear the click when the retraction of the spring happens. Once that happens, you know that you are in the abdomen. The maximum flow rate that the Veress needle will allow will be around 0.2 liters per minute. The point of insertion can be the Palmer's point or the Lee's point or the Jane's point, but usually the Palmer's point is good. Following introduction of the needle, you use a syringe to aspirate to make sure that there is no contents and no blood. And then you can also inject around 10 cc of air and aspirate again to see that the air should not come back out. If you can aspirate air at that point in time after injecting, you are in a closed space, probably pre-peritoneal. You can also do the water drop test. So trocars can be disposable, reusable, 2, 5, 10, 12 mm pots are used. In pediatrics, we use pots which are smaller in size. So 5 mm telescope and 3 mm working pots. In adults, usually a 10 mm camera with 2 5 mm pots should be sufficient. The obturator tips are blunt or bladed. The blunt is better. If you are using bladed or disposable trocars, you must make sure that the tips are sharp. If it is unsharpened, it will result in a forceful thrust and increased risk of vessel or organ injury. Now, introducing the trocar, your pneumoperitoneum should be adequate. The skin incision should always be larger than the diameter of the trocar. Otherwise, skin gives resistance and you can use excessive force. The trocar should be inserted perpendicular to the abdominal wall. Once you cross the peritoneum, you can change the angulation to your liking. Once you have removed the obturator, open the side channel, and once you open the trocar valve, you will hear egress of gas. That confirms that you are in the abdominal cavity. The primary camera pot should be in line with the structure at 45 degrees angle. The working pot should be on either side of the camera pot and at an adequate distance to allow triangulation. The triangulation rule must be followed for the placement of trocars as the body habitus is different for each patient. So 4 finger breaths between the optic trocar and the working trocars, and 5 finger breaths between the working trocars. If we are using a 30-degree telescope, the point, so the marking in the center, that is for the camera. And this is usually lateral to the umbilicus in PUJ. The two working pots can be in line with the camera or they can be lateral. This depends on the pathology, on your comfort. I usually prefer to go a little more lateral. And in pediatric patients, sometimes one line would be better. If you are using a 0 degrees camera, is the advantage of a 0 degree camera is that you don't really need a very great assistant. Anybody can assist with the 0 degree camera. If you use this, the first camera pot should be at the lateral border of the rectus and 1 finger breadth below the costal margin. The two working pots should be 4 finger breadths like a triangle. So the two working pots are, So the two working pots are below, giving you a triangle. So this is the final. You don't need so many ports. 3 ports are sufficient for pyeloplasty. Just in pediatric patients, principles are the same. Triangulation distance decreases. So you don't need that much distance. The smaller pots may be used and pots can be in the same line. Nothing teaches us better than our experiences. Thank you.
Dr. Suraj, just a second. Yeah.
Yes, sir.
The port placement are the usual difficulties placed for an initial surgeon. So how do you alter the port placement in case of giant hydronephrosis? That's one. In giant hydronephrosis with the pyeloplasty, how do you alter it? And in cases with the small intrarenal pelvis, you always break the table, and how do you change your port?
So for giant hydronephrosis, what I usually do is I puncture it. I put a small needle, in initial puncture needle, and I deflate the pathology. Once that is done, I usually follow the same pots which we were using. It is easier that way, because in giant hydronephrosis, if we directly try to put the ports inside and the varus needle, we will invariably cause injuries and enter into the collecting system. So usually I like to decompress it and then proceed with the pyeloplasty.
Suraj, we actually were looking for in your talk to look at how you would place ports for a left-sided pyeloplasty, for a right-sided pyeloplasty, for a pelvic kidney pyeloplasty, for a retroperitoneoscopic pyeloplasty. So people sitting here are very intently looking at your presentation to see how they can go back and place the ports. Those briefs were not really fully addressed in the talk.
Correct.
So that was what we were actually looking for in this.
Correct, sir. Correct.
Okay.
So usually the principles for that would, for right and left, are essentially the same. That you put the camera pot on the lateral aspect. It should be in the center. There should be 4 to 5 finger width, 6 to 8 centimeters. You can go little more lateral for the working pots.
That's all fine, because the right kidney is lower, the pelvis is lower. There is a liver which comes in. So do you need a liver retraction?
A fifth. So that's
do you need more, or you need a hitch stage? Where do you, if you are planning a hitch stage, how do you modify your port placement? So these are little issues which actually I think those discussions were.
That fifth pot was for that. Yeah. So if we have a liver.
But anyway, we are struck on time. Thank you.
Yes, sir. Thank you, sir. Thank you.
Yeah, thank you very much.
Dr. Nitish Kumar, please proceed with your talk, sir.
Good morning, respected delegates, mentors, and my dear colleagues. Greetings from Patna. I am very much delighted to be present back in Hyderabad, where I was being taught and trained in Osmania Medical College. I will be presenting on pyeloplasty. How do you stent? To disclaim, I was surprised at first because the only way I knew was integrated stenting. So I started searching and found that there's more than one way to skin a cat. The video contents are from different surgeons, credit to them and the YouTube. So to introduce, minimal access pyeloplasty is an effective and safe treatment modality for UPJ obstruction and the transanastomotic double J stenting in one of the critical stages of the operation. It helps to facilitate the stent urine drainage across the repair and also helps during post-operative edema and healing. But still, there is no consensus regarding the optimal approach, which is retrograde versus antegrade, and the timing, preoperative versus intraoperative to retinal stent placement. But there is a significant component added to the overall operative time. The technique of antegrade stenting, it's performed after the completion of the posterior wall of the retropelvic anastomosis. And the introduction of a stent can be done through existing laparoscopic port site. We can see on the middle, but the problem is there's an angulation, and so there will be a difficulty in cannulation. We can use either a suction port or laparoscopic suction port to introduce or cannulate the stent and the stent and the guide wire. You can use it directly or we can use it over a guide wire. You can also use an amplus dilator through a port to introduce or place it. After the stent is placed, it is the upper coil is to be carefully placed inside the pelvis for a better retention. The introduction of stent can also be done through a needle puncture through the abdominal wall. The advantage of this needle puncture is that we can place it in line with the new UPJ, and the wider bore IV cannula or the angiocath on the right side. It helps that a 3 French stent can pass in directly. We can also manipulate with the ports whenever required. We can either use a various needle or the initial puncture needle of a PCNL thing, and the advantage of these is that when we use a longer needles, it's easy to manipulate and reach the PUJ. Sometimes partial reduction of the pneumoperitoneum will also help you to achieve your goal. So it has certain advantages that there's no need of repositioning a patient from lithotomy to lateral one. It's faster, and many modifications and flexibility in the techniques are available. You can see in the papers that it affects the total stenting and the total operating time. So it's also facilitates better anatomical delineation and dissection around the UPJ since the renal pelvis remains distended and there's no interference of stent during the dismemberment and anastomosis. But it has certain disadvantages like the learning curve associated with the antegrade approach, and the confirmation of the distal end of the stent location, the bladder, can also be difficult. And the most important is the evaluation of the distal ureter to rule out existing ureteral stricture cannot be performed without previous retrograde pyelography. You can see a nice UPJO, you go in with laparoscopically, you do dismembered pyeloplasty, but later on the patient comes with long segment stricture and you have to tie it with a PCN and send the patient home for a later placement. And sometimes it's very difficult to pass a stent in antegrade manner. You try passing a stent, does not cross the VUJ, you try some different maneuvers, try passing a feeding tube, you again try stenting, it doesn't go. Then you try some different maneuvers like passing a ureteral catheter, it also doesn't go. You try something different, you try thinking, you try to pass the stent on the side of the guide wire, it doesn't go. In these circumstances, the only way that will help you or that is definitive is the retrograde stenting. The technique, it's performed in a lithotomy position before starting the laparoscopic procedure. A nephroscope or a ureteroscope, even a cystoscope can be used. A ureter can be cannulated with a guide wire and then a stent can be placed over it. The advantage of this technique is that you can confirm the distal end of the coil that is inside the bladder, and you can also do a RGP. So the advantage it's most familiar approach to the urologist and can be performed before or in conjunction with the pyeloplasty, and the ability to perform a RGP before the procedure. It also excludes any concurrent pathology distal to the UPJ obstruction. It also aids in identification of the ureter during the laparoscopic dissection, especially of value in secondary reoperative repairs, and the stent position can also be confirmed more accurately in antegrade manner. Certain disadvantages of the retrograde techniques are because there's a difficulty of dissection of UPJ due to collapsed pelvis, and the presence of stent will hinder the dismemberment. There's a chance of injury to stent and the subsequent suturing, especially the posterior wall. There's also need to reposition the patient during the surgery, and so it takes more time than the antegrade stenting. There's a modified combined technique in which ureteric catheter is kept with or without guide wire below the UPJ, and then the retrieval of the guide wire is done from the ureteric catheter from subcostal port after the posterior layer anastomosis is done. And then you remove the ureteric catheter and pass the stent antegradally and place it inside. The advantage of this technique is that the injection of withdrawal of the fluid through the open-ended catheter is useful to aid in mobilization of the UPJ. There is an intraoperative access to the catheter allows for direct handling during the anastomosis and suturing. It also avoids the difficulty of cannulating the ureter antegradally, that's the most difficult part, and also confirms that the guide wire has crossed the VUJ and a stent is correctly placed. It also minimizes the possibility of subsequent stent migration. In this, a patient is placed in a lateral position. Females are placed slightly different to expose the perineum. A flexible ureteroscope is done. A guide wire is placed. And then a ureteric catheter is placed. RGP is done. A C-arm is rotated like this. And then the retrieval of the guide wire is done from the subcostal port. And then antegrade stenting is done. Sometimes you can place an external internal stent where there is no need to pass it through the lower end of the ureter or VUJ, and you can use a splittable metal sheath so that there is no need to remove it. Sometimes all the thing that you need is your set of skills. You can orient the guide wire parallel to the ureter. You can place it inside. You can pass the stent and place it in the pelvis. Thank you.
Dr. Nitish, while performing pediatric pyeloplasties, what difficulties you encounter while doing an antegrade stenting, how to overcome it? And second, in malrotated kidneys and horseshoe pelvic kidneys, how you modified your antegrade stenting? How do you decide on the length of the stent?
So the needle puncture technique is really helpful. And in those cases, you can just orient the place where you can get a line of passing or cannulating the guide wire through the ureter or the new UPJ, and you can select your point. You can directly go in with the straight needle or even the longer needles. You can go to the UPJ and then cannulate the ureter. Once the ureter is cannulated, the stent can be passed. Even the skin can be directly dilated with the Amplas-C or the facial dilators, and through the skin also stent can be passed. Sometimes in pediatric patients, there's a difficulty in passing the guide wire below the or across the VUJ. Sometimes this difficulty is encountered, and many times we have to revert back to antegrade routes also.
I have one comment to make, Nilesh.
Yes.
For the audience, young people. Actually, you have to keep the bladder full when you are doing antegrade stunting so that you can see that stunt has gone into the bladder. Sometimes the guide wire can go through the urethra. So what you have to ask the system, keep the balloon pulled so that bladder may get occluded at the time when you are doing antegrade stunting. Thank you very much. Thank you, Neil. Thank you very much.
Nilesh, one last comment on the whole thing is, when you do an antegrade stenting for all of you, use a new terumo, not even one single use terumo. Let the guide wire go across the uretrovesical junction. Then, according to the age, you look at the size of the stent. The second is there is an enormous debate which goes on between whether you should do an RGP or we don't need to do an RGP. But leaving that debate aside, any malrotated kidney, any abnormal kidneys, any redo pyeloplasties, it is mandatory that we do an RGP and then leave a ureteric catheter at least just below the PUJ so that you have access to the ureter, and you can, whether you would like to do an antegrade or a retrograde stenting, you still have access to the ureter. Thanks, Nitish, for bringing out a good point. Thank you.
Thank you.
Sir, please allow me comments. Yeah. Sir, two things, sir. When you are starting out, because I started out a few years back, there is no shame in doing retrograde for every patient. It makes you more comfortable with the device inside if you want to get people ureteric catheter inside. So when you are beginning to do pyeloplasty, it gives you more confidence. So if somebody chooses to do that, I think it is a fair approach.
No, I have never said that you should not do an RJP. I am saying there is a debate which we can always have. But if someone is doing an RJP for a pyeloplasty, I don't think I will say that something is being done wrongly. Absolutely no. Absolutely no on that.
So then the second reason is further towards things that were saying that once you pass the demo and your assessment, your bladder is partly considered 50 or 70 ml of fluid inside, and the catheter is stuck. And finally, when you put the stent inside, hold the stent and move it in your body. If your stent moves well, then the lower coil is definitely in your bladder. As opposed to this situation, if your stent does not move well for about 2 centimeters in the cranial caudal direction, then your stent is definitely in the lower end or in the.
Now, this is when you put the stent directly.
Yes,
Antegrade, when you put the stent directly, if you put the guide wire across first and then place the stent over the guide wire, now this issue will not come, because if the guide wire has to go into the bladder, it will go into the bladder. And this stent, if it doesn't go, it will get stuck at some point near the vesicle junction or somewhere. But if your guide wire is not going, it will revert back. You will not be able to put the guide wire in comfortably. You will feel a resistance on the guide wire. So my recommendation is the guide wire should go in first, then thread the stent over it.
Dr. Gopal? Yeah, please proceed with your presentation.
So good morning all, and thank you USI and you for giving me the opportunity. So all you need about the suturing pertinent to the laparoscopic pyeloplasty I'm talking. So suturing in laparoscopy is has learning curve, because you need to, the extraoperative surgery for laparoscopy is very easy, but for pyeloplasty suturing is required, and that has a learning curve of around 20 to 25 cases. It has 2D vision and no depth perception. This is dedicated to all novice laparoscopic surgeon. So what we need is for suturing is high definition vision with 30-degree scope and needle driver, appropriate suture, and good assistant. So coming to the needle driver, it is found that for the novice laparoscopy, if it is done with the pistol grip, it is better. And like the pistol grip is seen in of the Ethicon, this and these two grips, they have better handling and better ergonomics for the novice. So these are the various types of needle holders. This last one is a self-writing needle tip. If you just put the needle, it will straighten up and hold properly. So type of suture, for pyeloplasty pertaining to good knot security we should have. It should have adequate tensile strength, flexibility and ease of handling should be there, inert and non-allergic nature, and resistant to infection. A smooth passage through the tissue and absorbability when desirable. So suture size, the surgeons should use the smallest suture that they are comfortable with, and that will give optimal security of wound closure with minimal wound tension. For pyeloplasty, we use around 40 Vicryl, and for uretrovesical anastomosis, 30. So the length, what we should use is around 6 inches for pyeloplasty, around 10 to 15 centimeter. And you can use for posterior other suture and anterior other suture. Play. So this is before starting on human, you can try on the chicken. So why on chicken? Because it will give more realistic feel of the tissue when you do chicken. So this is how you have to drive your knot through C. So see, this is the what you see, what you are seeing this end, appearing as a ureter is the esophagus of the chicken, and this is like a pelvis. It is the crop of the chicken. So you can put one IFT from the esophagus to the crop and distend it so that it will mimic the real PUJ situation. And once posterior anastomosis is done, you can put IFT and do the anterior stitch. Here the heat stitch is taken here so that for beginners especially, you can take heat stitch so that you can orient your suture, and the suture line will approximate easily if you take heat stitch. And that stitch will be through the skin. You can adjust the lever of that heat stitch so that the end of the pelvis and ureter will come approximate to each other, and the pyeloplasty will be easy. So this is how we do on the wet lab, and this is the pylotomy closure. Before starting on patient, we do around 20 chicken pyeloplasty in a wet lab, and then we start on the human. So like what you have seen is same, like we have done the chicken pyeloplasty that mimics the pyeloplasty on the human on the right side, not on the left side. And this is better for the novice to start on the right side, because you are a right-handed person, spatulation is easy, suturing and driving the needle is also easy. So in all cases, I have shown that it is a continuous suture we are taking. But there are some indications. There is the controversy. There are some people who say that we should take interrupted stitches. This is a surgeon's own preference. But the time consumed for the interrupted suture will be more. So there are head-to-head comparison for the continuous as well as interrupted suturing in laparoscopy. This is published from India only, and continuous suturing technique is preferred over interrupted because the success rate are equal, but post-op stay, suturing time and drain output and cost of the procedures are better. There's another paper who showed that the suturing technique has no effect on the surgical outcome. So either continuous or interrupted, it is the surgeon preference. Thank you.
Dr. Gopal.
Yeah.
So the common difficulty placed while starting a laparoscopic pyeloplasties, how you take the first stitch, that is a common difficulty faced, and especially when we are doing a pediatric pyeloplasty, the ureter will be so small.
Yeah.
And what is your tip when taking a first stitch?
First stitch will be taken by holding the tip, the advent tissue of the ureter, just outer surface, we have to hold with the left side, and the opening will be seen, and then we can take. Other is some people will put a retrograde catheter that will help to hold the ureter and take the stitch at the angle. Generally, it is seen that now we are not taking at the apex. We are started in the paraapical suture.
Yes.
So because sometimes we take, there is a tension of taking at apex will lead to sometimes stenosis at the anastomosis. So we start one interrupted suture is taken at paraapical suture, a paraapical area, and then we start continuous suture.
So you take a first stitch in the paraapical area,
Yeah.
and then afterwards you take the stitch on the apex. Yeah. The point is well taken. And regarding the pediatric patients, pediatric small incident less than 1 year, and how much distance you take, it will be different. I mean, how you do the suturing in a pediatric.
No, while taking on ureter, we are just taking at the margin only 1 mm only. But on pelvis, you can take more area of the pelvis, and you can put guide wire over guide wire also. It can be taken.
And one small thing, instead of you holding the ureter, always cut the pelvis adequately. If the pelvis is large enough, hold the pelvis, and with that minimizing the handling of the ureter. Okay. Thank you.
Thanks.
So Gopal, I think,
Yes.
well, I think you've shown the basic suturing things well. But looking at the program, I think there are 2-3 aspects which I thought I should make a point. One is that you need to assess your size of the pelvis and the ureter, and then make sure that there is no tension at the anastomosis. What I always do is I put a single knot, not even a surgeon's knot, and that should stay put. The ureter should not go away from the pelvis. Then you will have a tension-free anastomosis. After that, you can do whether you do interrupted, whether you do continuous, one-sided interrupted, one-sided continuous. All that, I don't think it has made any difference in our outcomes. The other important thing is the spatulation of the ureter. There are 2 aspects of it. how do you know that you have adequately spatulated? Is one people say that you can see the longitudinal folds of the ureter, but how do you assess that you have done at least a centimeter spatulation? So anyone can give me an idea, how do you assess that you have done a 1 centimeter spatulation without using a ureteric catheter or anything? So the simple thing is a 3 mm instrument will open to about 1 centimeter. So when you cut, when you open the jaws of a scissors, generally it is about 1 centimeter. So then you will be able to assess whether you have done an adequate spatulation or not. And always make sure that even if you have to go down, doesn't matter. You will have to do a renal diseases, but doing an adequate spatulation is an extremely important step. And this is what will make your pyeloplasty stand out subsequently. Otherwise, all of them are going to come back. The third thing is usage of a barbed suture. As of today, the data which is available is that we are not supposed to use a barbed suture in PUJ obstruction because it causes ischemia of the anastomosis. And out of 6 of the pyeloplasties which people have done and then randomized, 5 of them have been stenosed because of ischemia. So barbed suture is out of the question. Thank you, Gopal.
Thank you.
Raja.
I welcome Dr. Tarun, sir, to present on laparoscopic ureterocalcostomy.
Good morning, respected senior colleagues and my dear friends. I thank the USI and YOU conveners for giving me this opportunity. At the outset, this topic seems like the odd one out when we're discussing laparoscopic pyeloplasty, but in effect, it follows almost pretty much the same principles as laparoscopic pyeloplasty. And it is an important tool to have in the armamentarium of a reconstructive urologist. And I compare this to the Boari in the lower track, and this laparoscopic ureterocalcostomy can sometimes get us out of trouble in many situations. So this was first described by Newart, and then Calalis was subsequently instrumental in popularizing this technique. Gill described the laparoscopic procedure and Casal et al. The robotic. So the indications, salvage procedure for failed pyeloplasty. You could also do it in a primary case if there is a very small intrarenal pelvis or a altered pyelo-calicial ratio, and in secondary PUJ obstruction. So these are some of the anatomical features favoring a ureterocalcostomy in preference to pyeloplasty in the primary setting. One is, of course, thin cortex overlying the dilated lower pole calyx, recurrent PUJ with scarred pelvis, small intrarenal pelvis or altered pyelo-calicial ratio, and difficulty in ensuring reliable dependent drainage by conventional pyeloplasty, especially in very elongated kidneys when the lower pole goes up to L4, L5 or the sacral, or even up to the iliac crest. Here, doing a conventional pyeloplasty may not be the appropriate one, and because the drainage in these cases occurs mainly by gravity. There is loss of the interstitial cells of Cajal and the pacemaker cells. So it's mainly by gravity. In these situations, ureterocalcostomy would be preferred. So principles, one, complete lower pole amputation. It is very important to remove a disc of tissue. And in cases of thick parenchyma, we may need to take control of the hilar structures before cutting the parenchyma. Rest of the principles are pretty much same. Preserve periureteral tissue, wide spatulation, mucosa into mucosa, tension-free anastomosis. And closure of the lower pole capsule, it's debatable. It's preferable not to close it over the anastomosis because this can constrict the anastomosis. Of course, you have to close the renal pelvis or clip the upper proximal ureter, and omental or perinephric fat can be used to cover the anastomosis. So this is a case presentation here. This is a 30-year-old with a left flank pain showing a grossly dilated kidney, small pelvis, some stones in the lower pole. DTP renogram showed an upward curve with the blockage. This is the RGP. Port placements, almost pretty much same as lap pyeloplasty. can play the video. So the initial steps are pretty much same. We do the colon mobilization. I like to do all my kidney surgeries by initial mobilization outside the gyrotous fascia, whether it is radical nephrectomy or simple or even donor. And even in pyeloplasty, the initial step would be better to go outside the gyrotous and then open the gyrotous. The part of the colon has already been dropped. Here you can see the splenic flexure being mobilized. It may be necessary to mobilize a little bit of the splenic flexure because otherwise the colon keeps falling in the way. The instruments being used are a hook on the right hand and a bipolar cautery on the left hand. We don't need any fancy instrument, just a hook and a bipolar is sufficient. In the cases where the pelvis is dilated, it is better to mobilize the pelvis and then go to the upper ureter. But in such cases where there is a small intrarenal pelvis or a scarred pelvis or malrotated kidney, it is better to mobilize the ureter, upper ureter, and then go to the pelvis. While mobilizing the ureter, it is necessary to keep some amount of periureteric tissue to maintain the blood supply. Once this part is done, now we open the gyrotous and we localize the lower pole. We select the point which is the most dependent. The part of the gyrotous the perinephric fat can then be used later to cover the anastomosis. Additional fourth port can be put. This is usually a 5 mm port, but in this case, since I didn't have a 5 mm clip applicator, I've used a 10 mm port in the lateral part. We could also use a 5 mm telescope in the right hand port and put the clips to the umbilical port also. The proximal part of the ureter can be clipped or tied, and then the ureter is spatulated. I prefer to give an initial half circumference cut and then spatulate the ureter. The ureteric spatulation should be in a smooth cut to avoid tags, and it should be of adequate length to expose the ureteral rugosity. So once the spatulation is done, the ureter is then cut. The proximal most part can be used for handling the ureter. And here you can see marking out the lower pole parenchyma which needs to be excised. What's important here is to excise a disc of tissue. If we just make an incision, this can later cause stenosis. So remove a fairly good chunk of tissue. At the same time, we should not make it unduly large, because if the opening is very much larger than the ureter, then we'll have to close the parenchyma to each other, which is also not preferable. So there were some stones in the lower calyx. This was flushed out with the suction. It was just gravel actually, not really stones. The anastomosis is done with a 4-0 vicryl. The first stitch is at the paraapical corner. And after doing that, the needle is passed from under the anastomosis, and then we go outside in through the parenchyma first and then through the ureter. So the entire suturing comes as on the forehand. So the ureter is handled by holding the proximal most part, which is then later cut. Once the posterior layer is done, I don't tie it, I leave it outside the ureter. And then the stent is pushed through the left hand 5 mm port by using a suction tube and passing a guide wire, and over that the stent. So you can see here the posterior wall is done, and now we are suturing the anterior wall. This is also done with 4-0 vicryl, and now both the sutures are brought to each other, brought to the end and then tied to each other. 2 more minutes. So I was stressing on the length of the anastomosis. The opening of the lower pole parenchyma should be just about sufficient to complete the anastomosis. Yeah, so once this is done, the two sutures are tied to each other, and it is then covered with surrounding perinephric fat. So you can see these two sutures now, they're being tied, and then very important to cross the sutures, make a proper surgeon's knot. And here you can see the perinephric fat being closed over it. So post-op protocol is pretty much same as in pyeloplasty. First the catheter removal, then the drain, stent removal after 8 weeks. Thank you.
Yeah, thank you, Dr. Javali. Nicely showing the indications and then technique you have shown. I made the point very clear. Only one and two comments I had, which is again for the young people, that in such situation you have to assess when you can do pyeloplasty, which is easier, then you please go for pyeloplasty, even if the lower pole is dependent. You can't make it dependent on osmosis because there are other techniques available. Alternatives are nephropexy, or you can do nephroplacation. So yes, but it's a good technique for primary EPG of suction. You have to assess all the points before you again venture for uterocalcostomy. Thank you.
Tarun, a very nice case to demonstrate. Okay, but there's one thing which still confuses me is you have been taking the sutures along with the capsule of the kidney. The standard teaching is not to touch the capsule because that is what leads to the anastomotic stenosis subsequently. So the standard teaching is to do a mucosa to mucosa calyx to ureter to the calyx. You need to leave the tissue away. Maybe this case you may get away because there is absolutely very minimal parenchyma. You would not be doing a calycostomy and all, and this is a primary case. Majority of the cases we do a good parenchyma, we have to do a lower pole calycostomy. That case is it would difficult. So just would like you to tell us whether is there any shift in philosophy in the capsule?
Yeah, correct, nice point, sir. So in patients who have a very thinned out lower calyx and thinned out lower parenchyma, dilated calyx, we take a part of the capsule and the mucosa comes along with the stitch. However, in patients with a thicker parenchyma, probably we may need to do a mucosal eversion suture, and then it will be like dunking the ureter into the calyx. So in a thicker parenchyma, we should not take the capsule, but in such cases, it's immaterial. Mucosal eversion sutures. Yeah, point. So while doing rhinography, it's important not to do the raphy over the anastomosis. That will compress it. On either side of the anastomosis, you could do the rhinography.
Yes, sir.
Thank you.
Thank you, sir. I'm glad to invite Dr. Vijay for a presentation of transmesocolic.
Respected chairpersons, seniors and dear friends, thank you USI and the YUU for giving this opportunity. I also like to thank my guru, Dr. George P. Abraham, for teaching me laparoscopy. I'll be talking on left-sided laparoscopic pyeloplasty. So not much of theory. Now we've already diagnosed it's PUJ obstruction and we need to do a pyeloplasty, I'll go to the technique directly. Keep the patient fasting overnight. We always prefer a bowel preparation and a single dose of antibiotic prior to surgery. It's under general anesthesia, always preferable to do an RGP initially to decide what we are, or to even see what we are going to face inside. Place in a urethral catheter after that, and a NG tube, and 45-degree lateral decubitus. So this is a couple of RGPs. We know what we are going to face inside, how much is the length of the obstruction, and probably even crossing vessel on causing the obstruction. So in the lateral position, we usually have 4 ports, one para-umbilical, para-rectal, 10 mm for the camera, and 3 5 mm, two 5 mm working ports, and 1 5 mm laterally for the retraction. Then the pneumoperitoneum, and pressures around 12 to 15, and as I've already said, 4 ports. Yeah, so the initial part is a colon mobilization. You can either use a hook or a harmonic scalpel, go outside the gerota, and the colon is being mobilized here. I can see the subtle difference in the fat color, the difference in the mesenteric as well as the gerotal fat. The gerota is opened and the PUJ is dissected here. As you go close to the PUJ, avoid use of a cautery there, use of scissors there to avoid damage to the vascularity, that is the anastomotic area. Avoid too much dissection onto the ureter to preserve its vascularity. Now the PUJ is dissected well, you dismember it, and then spatulate it laterally. You can see the sprouting mucosa on the ureteral side to decide the healthy ureter. The narrow segment is excised, but then as you see, there is some tension, and that has to be definitely avoided. So it's not possible to anastomose with that tension. So you mobilize the kidney as much as possible and to get it down and reduce the tension on the anastomosis. Now, once the kidney is mobilized, you can see it's anastomosis much easier without much tension there. So you can start the suturing. The first stitch through the apex, we use 4-0 vicryl. The first stitch, apical stitch, is the most important one. Then you fix the ureter onto the pelvis. Here, there's not much of redundant pelvis, so we can just finish it off without any reduction. And then once the 2 stay sutures are taken, one in the apex and the other side, and 3 sutures in between the 2 stays, and then you rotate it and then go for the posterior wall. Once the first stitch on the posterior wall is taken, the initial puncture needle is it's used, and the guide wire is placed, and the stent goes through that. Place it well into the pelvis, and then complete the anastomosis. Another 2 or maybe 3 stitches. It's all interrupted, not continuous suture. We finish the anastomosis there. That is the last stitch probably. So that retraction, the 4th port helps in retraction. That's the completed view. This is one, the crossing vessel can be seen here. So you dismember it and then take it anterior to the vessel and then complete the same procedure as shown earlier. Now, if there's too much of redundancy, you can cut the excess pelvis, and then after the primary anastomosis, you can use a barb suture, V-lock suture, and reduce the pelvis. So the redundant pelvis can be excised, that is removed, and then the barb sutures helps really in this. You can do a fast suturing with that. So that is the completed procedure. That's the anastomotic area. So in pediatric patients or in very thin individuals, we can do a transmesocolic pyeloplasty. That's possible only on the left side, in which the left mesentericocolic space is dissected out, and which is defined by the inferior mesenteric vein medially and laterally by the middle margin of the descending colon, and the incision is made longitudinally along that, and then the PUJ is dissected. This is the pictorial representation. This is the post surgery. I'll show the video. So this is the area which I was talking. There you open the peritoneum there and dissect the pelvis and the PUJ through the mesocolon. The anastomosis and the rest of the things are almost pretty much the same. You spatulate laterally. And then take the first apical stitch. Not much of tension here, not much of redundancy as well. So it's almost the same. We place a stent once the posterior wall, the couple of stitches on the posterior wall is taken, and then finish off the anastomosis. So we have not mobilized the colon at all here, and we can do it transmesocolically as well. So here, as I said, no bowel mobilization is required. The operating time is less. Early bowel recovery because the colon has not been touched at all. But it's possible only in children and thin individuals where the mesentery is very thin. There is a theoretical risk of chronic ischemia, but it's not commonly seen. And the pelvis, if it's it's little intrarenal, it can just get retracted beneath the colon. Thank you.
Dr. Vijay, here you use the barb sutures only to close the pelvis,
Only
and not
close-
only to close the pelvis.
Only to close the pelvis, never on the primary anastomotic area.
Yes, thank you.
Only one comment I would like to make. Nice presentation, Vijay. For people who are thinking, which case should I do a transmesopolic, which case should I not do a transmesopolic case? If you can see the pelvis nicely, ureter nicely, the colon is sitting lateral to the kidney, then you go ahead with the transmesopolic. If the colon is sitting medial to the kidney, at the medial edge of the kidney, you're not able to see the pelvis and all, don't venture, do a colon deflection. You still can argue with me saying that, okay, can't we do it? You need one more port, you need one more sutures, pull the colon up and do all sort of jugglery. So the basic rule is you see the pelvis ureter nicely, colon is sitting lateral on the wall laterally, go in with the transmesopolic. And you should also be sure that the stricture is small, so that if you have a long stricture at the ureter, you will not be able to do a renal decensus and all that. In case, the other issue is in case you have to mobilize the colon, make sure you close the mesocolic rent, because enough cases we have seen in pediatrics where there are internal herniations. So at that point, you'll have to close the mesocolic rent. Thank you, Vijay.
Thank you.
Now we have the next speaker, which is from Mr. Shanky Singh, and he's Dr. Shanky Singh, and he's giving a lecture on minimal invasive pyeloplasty in anomalous kidney.
Good morning, everyone. Myself, Dr. Shanky. Today, I'm going to present minimally invasive pyeloplasty in the anomalous kidney. So how to change? This one. Okay. As we know, the anomalous kidneys are of various types, depending upon the various embryological and development defects, which can be during ascent leading to an ectopic kidney, in which the pelvic kidney is the most common. There can be a form and fusion defect leading to a horseshoe kidney, a cross-renal ectopia, a unilateral fused kidney with inferior or superior ectopia. There can be a rotational defect leading to a malrotated kidney with a ventral or ventromedial, dorsal, and a lateral position of the pelvis. There can be a duplication of the collecting system leading to a duplex system, which can be incomplete or complete. POGO usually associated with about 25% of the horseshoe kidney or an ectopic kidney, and 2 to 7% of the duplex kidney. Oh, sorry. Now the various approaches for the minimal pyeloplasties are laparoscopic and robotic, which can be done transmesenteric, transperitoneal, or retroperitoneal. The different procedure Laparoscopy, like a normal kidney, like we have a dismember Henderson-Heinz pyeloplasty, which is most commonly performed, followed by non-dismember like Foley's 5V, Curb-Lee Wiertz, Cardino Prince, and Fenjo pyeloplasty. Basically, the aim remains the same. We have to have a widely patent-dependent funnel shape, watertight, and a tension-free anastomosis. The other procedure which can be performed, enormous kidney or pylovasculostomy, like in pelvic kidney with PGO, uretocalicostomy, calicovasculostomy, calicoureterostomy, and a nephrectomy when a contralateral kidney is normal and previous surgical attempts have been unsuccessful. This was a series in 2004 made by Bow and team from Johns Hopkins, in which they have done 5 lap Anderson-Heinz pyeloplasty in anomalous kidney, and 3 Henneque-Milclis and 3 Foley's 5V in anomalous kidney, with a success rate of 91%. Now, the basic surgical management of the POJO and anomalous kidney also remain the same, in which we should have a good preoperative imaging like a 3D reconstructed CT urography, which will give a good anatomical delineation of vasculature and help us to decide which type of surgical procedure we should use. Sometimes an RGP immediate before the procedure can also help us to redefine the pathological segment. Now, the position in anomalous kidneys are usually lateral decubitus or a tenderable position in pelvic kidney. The port placement are as shown. When you do a left, there's a left flank ports which are puts in right anomalous kidneys, right flank ports, and pelvic kidneys, the pelvic ports, which I'll discuss later on. Then the basic steps of the pyeloplasty also remains almost the same, in which you have a colon mobilization, restriction of thermal energy during ureter and pelvic mobilization, dismembrane of a pathological segment, transposition of the anastomosis anterior to the culprit vessels, spatulation of the ureter widely and pelvis spatulation in a contralateral direction, uretropelvic reconstruction, or redundant pelvis if there exercise, and stent placement. Now, if we go to specific anomalous kidney like a horseshoe kidney, which is one of the most common renal failure abnormality, in which the kidney failed to rotate and the pelvis and ureter are atypical in orientation, usually in an anterior position. The most common factor which leads to POGO and horseshoe kidneys are anomalous vascular supply, high insertion of ureter, abnormal course of ureter over the isthmus, and intrinsic pathogenesis. So pre-operative imaging is essential for proper delineation of the renal vasculature. The position and procedures are like we have a lateral decubital position for a horseshoe kidney. Conventional 3-port techniques are used, which are positioned usually more inferiorly on the abdomen than a conventional technique. In young children, the trocar can be inserted away from the midline on the same side as the surgeon. Now, if you have a short stenotic segment, then you can go for Anderson-Heinz pyeloplasty in horseshoe. If you have high insertion ureter, you can go for Foley's 5V. If you have a large extrarenal pelvis, you can go for Scardino vertical flap pyeloplasty. Others are like vascular hitch and uretocalicostomy, depend upon the indication. Sometimes isthmectomy and lateralized inspection of the lower pole to the psoas is performed if the isthmus visibly obstructs the outflow. The principle of surgery in horseshoe remains the same. Due to the low renal position in horseshoe kidney, the ureter is isolated in close proximity to the iliac and other pelvic vessel. So a direct manipulation of a crossing vessel if present is avoided in order to prevent vessel injury and potential compromise of the lower pole parenchyma. Instead, traction on the ureter and pelvis is alternated to expose the attachment to the vessel until the ureter slides freely beneath it. Sometimes Hellstrom stitch is used when there's a crossing vessel with associated fibrosis, having a small renal pelvis and a normal appearance of the UPJ and ureter. Here, the preservation of the perivascular tissue is done and a distant relocation of the vessel about 2 centimeters or greater are done. The result of lap pyeloplasty in horseshoe kidney is about 78% success rate compared to 90% in a normally placed kidney. And it has the same success rate as an open pyeloplasty in horseshoe kidney. Other anomalous kidney, what we have is a pelvic kidney, which is the most common location of an ectopic kidney. In this, the main thing is to evaluate the contralateral kidneys also, because you have a 25% hydronephrosis in the contralateral kidney. Mainly the surgical challenge is location deep in the pelvis below the aortic bifurcation and shielding by the sacrum. The port placement is usually at the level of umbilicus. Camera port is at the level of umbilicus. You have 2 working ports. One is at just above the suprapubic region, a working port, and one is at the 5 mm port in the mid-clavicle line on the line of the camera port. Position is supine with a 30-degree upward tilt. And a port, sometimes a 4th port can be used to improve the exposure. The first difficulty usually encountered in pelvic kidney is to identify the basic poles, upper and lower poles. Usually this can be sufficed by seeing the peristalsis, renal pelvis peristalsis. What care we have to take is about an anomalous vessels, which come from middle circular artery, iliac arteries, and aortic bifurcation and the aorta. Care must also be taken not to twist or kink the anastomosis. This is a dismember pyeloplasty done in high inserted ureter in pelvic ectopic kidney. Post-op showing the resolution of the hydronephrosis. Now, the anomalous kidney, you have a duplex system, which is usually associated in about 2 to 7% of the cases with PUGO. The most common obstruction site is at the lower moiety compared to the upper moiety. And we should be like in a patient with a proximal ureteric confluence, precaution should be taken not to damage the ureter and the pelvis of the unaffected renal moiety. Now, these are the various procedures which can be done depending upon the specific anatomy of the case. If the lower pole is long or it is complete, then a lower pole Anderson-Heil pyeloplasty can be done. Here. If the lower pole is short, then you can do directly pyloureterostomy. If the lower pole is hydronephrotic and the PUJ is difficult to define, then we can go for ureterogalicostomy. If the lower pole is not functioning, then you can go for lower pole heminephrectomy. And if you have like upper pole dysplastic, then you go for upper pole nephrectomy with the ureteropylostomy. Then you have a cross view ectopic pelvic kidney, in where the kidney is located on the side opposite from where the ureter is inserted into the bladder. Here also the position remains supine with a tilt of 20 degree in Tendelberg position. Here also 3 ports are mainly used, 2 10 mm periumbilical and pararectal and 1 5 mm. Here the most important thing one can do is in affected site, you can put a ureteric catheter, or you can do a RGP, and you can also put a dilute sterile methylene blue to identify the affected pelvis and ureter. Care is taken to avoid injury to the normal ureter. This is one of the pictures showing ectopic kidney, ectopic pelvic kidney. Now here is a cross renal ectopia with an unusual form of fusion, with inverted U shape. Here the fusion is at the upper pole, and here the laparoscopic ureterocalicostomy was done, leading to the resolution of the hydronephrosis. Then a dismember pyeloplasty can also be done in a malrotated kidney. The one thing which should be remembered, there should be anterior, not inferior, and the drainage should be comparatively like anterior drainage should be there. Then you have a single port less pyeloplasty. Here a 2.5 centimeter incision at the umbilicus can be done, and 3 port can be positioned. Laparoscope is placed with the most medial trocar and position anteriorly in the abdomen. Various articulating instruments can be used. One thing is important that you have to do a retrograde stent here. Antegrade stenting will be difficult. The last is a retropyeloscopy pyeloplasty, where 3-port technique is viable and feasible option. Here, the absence of bowel handling and minimal possibility of pyrethroid contamination is an advantage, while the disadvantage is a limited working space for instrument handling and intracorporeal suturing. The take-home message is that laparoscopic pyeloplasty can be successfully conducted in presence of anomalous renal unit, though the surgery time is more prolonged due to mobilization of kidney and ureter pelvic complex. But the overall functional success of pyeloplasty in different congenital anomalies is 69%. Thank you.
Thank you, sir.
Thank you, Dr. Shank.
Thank you, sir.
The one important point is in an anomalous kidney, the role of RGP is very important, and always place a ureteric catheter just below the. It will save a lot of trouble. Thank you.
Thank you, Shanky. I think I may call upon Dr. Mohammed Gauss to speak on intrarenal pelvis and giant hydronephrosis. Thank you.
Good morning, respected seniors and dear colleagues. I welcome you all to Hyderabad, and I thank you to giving me this opportunity to speak on dealing with intrarenal pelvis and giant hydronephrosis in a laparoscopic or a robotic pyeloplasty, that is minimally accessed pyeloplasty for a beginner. The basic principles of pyeloplasty still remain the same, even if it's a intrarenal pelvis or a giant hydronephrosis, that is excision of the atretic segment, repositioning of the crossing vessels if at all they are available, flap of the normal pelvis wall into the narrow segment, preserving vascularity, avoiding tension, and diversion in the form of a PCN or a stent. This has all already been discussed. You will have to have there's no fixed position because every configuration of the dilated pelvis is different. One has to maintain a triangulation if you're doing a laparoscopy, should maintain adequate distance between the ports and should have a adequate angle, a manipulation angle for adequate suturing. Coming to the intrarenal pelvis, what are the scenarios that wherein we'll get this intrarenal pelvis? One is a normally oriented kidney with an intrarenal pelvis, a posteriorly malrotated kidney or a kidney with multiple hilar vessels where anterior approach might not be possible, an ectopic kidney with an intrarenal pelvis, a dilated lower calyx with an intrarenal pelvis, or a cicatrized intrarenal pelvis which is already fibrosed. Majority of these intrarenal pelvises are managed by doing a YV plasty. This is a standard YV plasty in a normally oriented kidney, wherein a lower pole is slightly lifted. An incision is given onto the pelvis in a V shape and a spatulation onto the ureter to form the long limb of the Y. The V incision onto the pelvis is now brought down into this long segment of spatulation and then anastomosed. Once the posterior layer is done, a stent is placed and the anterior layer is completed. This is a standard YV plasty for any intrarenal pelvis in the normal orientation. Suppose if you have a posteriorly malrotated kidney wherein the anteriorly you are not able to assess or you have got multiple hilar vessels. In that situation, the entire kidney is mobilized medially. A hitch is taken so as to have an orientation and maintain the traction onto the pelvis. Ureter is spatulated and the similar anastomosis is done. This can also be done through a retroperitoneoscopic approach if you are not already have gone through the transperitoneal approach. This is a completion of a medial flip approach for a intrarenal pelvis. An ectopic kidney with an intrarenal pelvis, again, the similar approach here. But here, because the pelvis and the ureter are tightly stretched over the pubic rim, one cannot stretch back that V of the pelvis down into the ureter. In such situations, a lateral flap is taken, and this flap is anastomosed side to side to the incised ureter. This is the incision for creating the lateral flap of the pelvis. Once this is done, a side to side anastomosis of this flap is done to the incised ureter. Stent is placed and the anterior closure is done. The adequacy of this flap reaching the incised ureter is assessed and then suturing is commenced. Always we follow this parapical suturing as discussed previously. Stent is placed and the completion suturing is done. In situations where you have got a dilated calyx, ureter calycostomy primarily is preferred because you've got an intrarenal pelvis and a dilated thinned out calyx at the lower pole. As previously described, a lower pole is mobilized, the gyrotous fascia is open, the stenotic segment is divided after a clipping, a ureter is spatulated, and the area just next to the spatulated ureter is identified onto the lower calyx. This is the perinephric fat being cleared of this lower calyx. Because this being a thinned out a lower pole with a very thin parenchyma, a primary anastomosis is done side to side with the spatulated ureter. This is almost like a regular pyeloplasty, but at the lower pole. Again, similar outside in, inside out sutures at the parapical area of the spatulated ureter. At the lower end, posterior layer of closure, stent, and then anterior layer closure. This is the completion of the posterior layer. Again, a parapical interrupted suture at the lower end, stent, and then closure of the anterior layer. If you have got a cicatrized intrarenal pelvis with a previous surgery or a patient is already stented and who has presented with sepsis, you cannot mobilize the pelvis which is already intrarenal, neither the ureter can be mobilized, everything is stuck to the posterior abdominal wall. In such situations, kidney is mobilized medially as the pelvis is a posteriormost lying structure. An incision is given longitudinally across the PUJ, distally onto the ureter to spatulate. The distal patency is ascertained with a feeding tube. The long length of incision onto the ureter and the pelvis is measured. A stent is placed and a buccal mucosal graft is augmented onto this area and augmented BMG pyeloplasty can be performed. This is done as cicatrized pelvis, where you cannot mobilize neither the pelvic wall nor the ureter. This is the posterior layer being done. You already stented it with the anterior layer closure, and the kidney is repositioned back into its position. To summarize the intrarenal pelvis, what are the options? For intrarenal pelvis, normally oriented kidney is YV-plasty. For a posterior malrotation, either it's a medial flip pyeloplasty or a retroperitoneoscopic pyeloplasty. For an ectopic kidney with intrarenal pelvis, you've got a pelvic rotation flap. A dilated lower calyx, you can do a ureterocalicostomy, or a cicatrized intrarenal pelvis, one can do a BMG augmentation pyeloplasty. So, coming to the giant hydronephrosis, what actually is giant hydronephrosis? When you have got more than 1 liter of urine in the hydronephrotic sac, the contents of the sac is equivalent to the average daily urine output of, for that particular age. Kidney that occupies hemi-abdomen or crosses the midline and is covering more than 5 vertebrae. What are the indications of pyeloplasty in such hydronephrosis also? Wherein we have got young patients with contralateral renal disease, solitary kidney, renal insufficiency is already there, or you can think of a salvageable parenchyma if it is available. The most common approach for a giant hydronephrosis is by doing a reduction pyeloplasty. One has to be aware that majority of this giant hydronephrosis have a lower polar vessel. You decompress the pelvis, take a tacking suture so as to have an orientation and counter traction. Do a large reduction of the pelvis. Divide the ureter at the level of the vessels. Deliver it from below the vessels and start commencing the suturing. Once the spatulation is done. Though the uretropelvic anastomosis is short, one has to close a long redundant pelvis after a long reduction. Dismembered pyeloplasty and Anderson-Heinz pyeloplasty for along with nephropexy has been described by none other than Eminenti sir, wherein in this publication he has clearly told the laparoscopic dismembered pyeloplasty is feasible and can be performed safely and successfully in children with a giant hydronephrosis. Another technique wherein laparoscopic nephroplication and nephropexy is done as an adjunct to pyeloplasty, wherein you have got a giant hydronephrosis with the previous indications. You also mobilize the lower pole of the kidney and fix it in such a way that gravity drainage can occur across the anastomosis. This is actually not a described procedure in a minimal access surgery, but rather one of the options when you have a when you can do a primary Bori calicovesicostomy. So what are the options that we have in a giant hydronephrosis? To conclude, we can do a reduction pyeloplasty, a dismembered Anderson-Heinz pyeloplasty with nephropexy, or you can do a primary Bori flap calicovesicostomy. And this is a regular post-op case, care that we do. And the take-home message is minimal invasive pyeloplasty can give an equivalent results if you have an intrarenal pelvis or a giant hydronephrosis. Selection and planning improves the outcomes, and complications are infrequent, but once they happen, they are morbid. I thank you all.
Thank you, Dr. Ghosh. Only one point I have to make it, that when you have sometimes you are finding difficulty in reaching to the hilum and keeping the area very easy for you to maneuver. So nephro actually passing a hitch from the kidney and then fixing it to the abdominal wall will keep the internal pelvis in front of you.
Correct.
So that you can do pyeloplasty well.
Yes.
When in case of giant hydronephrosis, when you take a hitch from anterior wall of the pelvis, hitching it to the anterior wall, keeping it again pulled up, again helps you in getting oriented. So these are the 2 points I would like to make. So thank you, Dr. Ghosh.
Thank you, Ghosh. It's a wonderful disposition of the various modalities of treatments needed in. So we need to know how we should choose which modality for what kind of pelvis it is. And that was nicely demonstrated by you. Thank you, Ghosh.
Thank you.
I call on Kizar to speak on stones with PUJ.
Good morning, everyone. I'm Dr. Khizarov, consultant urologist at Dr. Rov's Urocare. Dr. Rov's Urocare and Olive Sarvodaya Hospitals. I would like to thank USI and you for the opportunity to speak today. And I'll be speaking briefly about PUJ and PUJO and stones. Concomitant PUGO and renal stones have been scarcely reported throughout history, although PUGO on its own has been extensively studied throughout the years. There is still doubt regarding the pathophysiology and the global management of these conditions. PUGO is well described in literature as far as diagnosis and treatment is concerned, but the controversy is about the stone formation and the management in these patients. It was first described as a syndrome by Dietl in the year 1864. Subsequently, fibrotic changes were demonstrated by Allen in the 1970s. It is known that if left untreated, the narrow PUGO leads to deterioration of renal function. It could be primary, where there's dysfunctional smooth muscle and excessive collagen deposition leading to hydronephrosis. Secondary could be an abnormality where there's a crossing vessel or fibrous band. There could be extensive compression from a malignancy or a cyst. The prevalence of lithiasis in PUGO is higher than general population. The incidence is about 20 to 30% and high as about 35% in anomalous kidneys like a horseshoe kidney. There is very little literature on the ultrastructural changes. There's just one study which shows that the biopsies which were collected showed fibrotic changes. These were also demonstrated later in the 1970s by Allen. One hypothesis could be that the stone formation could cause local inflammation and edema, which could lead to a stricture. If at the time of endourological stone management, PUGO is suspected, it is better to defer the procedure until further imaging and nucleotide studies are available. A delayed washout is another hypothesis where urine stasis and nucleation could lead to stone formation. The metabolic causative factors is well known. Huseman et al. Studied 111 patients where he suggested that 111 patients with PUGO and stones, where he suggested that urinary stasis may not be the sole contributory factor. UTI and metabolic factors definitely play a role. And there was 31% incidence of struoid stones. There is varying level of hypercalciuria, hyperuricosuria, and hypocitraturia in 32.5% of the patients. 83% had underlying metabolic abnormalities, and subsequent management of these abnormalities led to a 17% recurrence rate. A long-term antibiotic therapy may be beneficial in patients with recurrent UTIs. Martin and Steam studied 47 pediatric patients, out of which 21 had PUGO with stones. They suggested that 67% had a metabolic risk factor, 93% had calcium oxalate stones, and phosphate was the additional material. Huseman in his previous study suggested that it was a 71% metabolic factor and 19% were pure PUGO. Coming to imaging before we go for a procedure or a collaborative procedure, we need radionuclide imaging in the form of DTPA or MAG with a CT where we could check for a crossing vessel as well as an IVP and RGP or MCUG to check if there is any reflux. The management is totally dependent upon when and how. It needs to be tailored depending upon the degree of obstruction, the deterioration of renal function, the symptoms of the patient. Some suggest that a stone less than 5 mm in size may be left alone. Some suggest that a stone greater than 5 mm in size and multiple stones has to be dealt. It is totally dependent upon the combination of modalities available to the surgeon and the skill that the surgeon has. Management options, the end goal is clear. For PUGO reversal, it is pyeloplasty, and for stone retrieval, it could be a combination. Minimal invasive procedures are preferred. It could be laparoscopic or robotic assisted, but there is no shame in going after it with open surgery. There is no consensus for the management of the stone. Here's a flow chart demonstrating the red flags that need to be kept in mind before we go in for a collaborative effort. A stag-on stone, a stone greater than 10 mm in size, a symptomatic patient, a non-dependent calyx, a complicated stone, and a single kidney are all indicators to go in for pyeloplasty with concomitant stone management. Other non-symptomatic patients and patients with no deteriorating renal functions may be managed conservatively. Here's a summary of results a few series which managed simultaneous PUGO correction and stone management. The most popular form of PUGO reversal was laparoscopic pyeloplasty. 2 series did antegrade pylotomy and retrograde pylotomy. The stone management varied. Some did a PCNL, some combined effort with a flexible nephroscope or a ureteroscope. The PUGO reversal was fairly successful between 90 and 100% in laparoscopic group. Just one series which showed a 50% reversal rate. The stone-free management was 100% in PCNL and varied between 80 to 90% with the use of flexible ureteroscope or a nephroscope. The mean follow-up was between 8 to 24 months. Coming to the conclusions, metabolic risk factors appear to play an important role. It is enough to justify metabolic evaluation in these patients. Urinary stasis and infection are well-known factors. The choice for treatment is not always straightforward and has to be tailored according to the patient's size of stones, the PUGO, the surgeon's accessibility to minimal invasive techniques, and simultaneous treatment is definitely feasible. Thank you.
Thing is, how do you manage these stones while doing a pyeloplasty? How do you go about it? And how you place a trocar if you were now?
If it is just a pelvic stone, then we can first if it's the multiple stone and lower calyceal stone, we first do a PCNL, then go for a laparoscopic pyeloplasty. If we are using a flexible scope, then we use on the left side, we use the right port to use a flexible scope and access the kidney, and on the left side we use the left port. Right side, sorry, left port.
So while doing this, how do you maintain the pneumoperitoneum? Any tips you maintain? How you maintain the pneumoperitoneum? How to prevent the damage to the flexible scope when you are passing through the trocar?
We use a larger size port wherever we want to access, where we want to use the flexible scope. The access sheet can also be used sometimes to place the port.
Praveen, to answer you, how do you can use an Excel trocar. So that will not allow you to get your scope in without much loss of pneumoperitoneum. And suppose you don't have an Excel trocar, you can actually remove the trocar, you can pass the scope directly to the port, to the opening. And if there is a leak, you can just take a small stitch, don't tie it, just pull it up so that you will be able to snugly fit it over the scope. And that way we will not damage the scope. Thanks, Kizar.
Thank you.
Thank you. I think the last thing, which is important, on Manar Singh Rajput to speak on simulation-based training on lap pyeloplasty.
Good morning, respected seniors and my colleagues. I'm Dr. Manar Singh Rajput. Thank you, USI, Youth USI, for the opportunity. Today, I'll be speaking on simulation-based training for laparoscopic pyeloplasty. So simulation is imitation of a process or a real-world scenario. And in certain professions like defense and in certain professions like defense and pilot, they have this type of simulation training, whereas in a surgical field, we have a classical teaching, that is a Halstedian way, which is see one, do one, and teach one. But in that training, there is a problem that we need more patients, and arranging lots of patients in the different institutes is a difficult part. So simulation training is the need of the hour. Laparoscopy is the gold standard in many urological procedures, and it has a gradual learning curve. But so the need for the dry and wet lab training is imminent. So why the need for simulation? In India, we don't have stipulated working hours during our residency, but it is very difficult to learn all the surgical procedures during our surgical training. And also there is caseload varies in different institutes. Some residents may get more endourology work, whereas some may get more uro-oncology exposure. And also there is increase in the number of residents in every year. There are three types of simulators. One is mechanical box trainer, animal models that can be cadaveric or live, and virtual reality simulators. The first one is a physical simulation model that is made using organosilicate material, and it is patient specific, anatomically oriented, and 3D printed molds are prepared, which is modified post printing. Here you can see the top, bottom, and endoscopic view of this simulator. In this one, the pelvis is of 6 by 3 centimeter in size, and the ureter is 18 centimeter in length. The second one is glove pyeloplasty model, where a simple glove is kept under the endotrainer. The glove finger acts as simulates as a ureter, and the palmar portion simulates as a pelvis. This is a low-cost simulation model, but with a low fidelity. The third one is chicken pyeloplasty model. This was developed by the team MPUH Nadiad. The chicken viscus can be assumed to be different human organs, and we can practice different surgical steps into this. So as you can see here, the crop can be considered as pelvis, the esophagus can be considered as ureter, and the trachea can be considered as gonadal vein. So compared to the previous ones, the animal models are better because we have more realistic simulation, tissue feels better, and various steps like dissection, cutting, dismembering, and suturing can be nicely performed. So to prepare the chicken pyeloplasty model, first we have to behead the chicken, feathers are extracted, and then the skin is kept intact. After that, the chicken crop is cleaned with tap water, and all the contents are flushed out. Then the feeding tube is inserted, and it is tied with a thread, so the contents does not come out. And then it is filled with the 50 ml of water. Now it is ready, and we can put it into the endotrainer. You can see here in this video, the dissection start at the crop. The skin over the crop is dissected, and which is extended over the esophagus, which mimics the direct dissection of anterior aorta over the ureter. Then the ureter is transected, and it is spatulated, as you can see here. Then the pylotomy is performed, and the angles, after taking the angle stitch, and posterior layer of suturing is completed in a continuous manner, followed by anterior suturing with a fresh suture. And at the end of this, both the, as you can see in the first image, both the sutures are tied, and you can also check the patency of anastomosis by injecting the fluid through the feeding tube. So here you can see the area of leak there is a gap between the two tissues. This one is the high fidelity model, but it has certain challenges, like currently an animal or a cadaver is used to train one procedure to one training, and arranging animals for purpose of training is not only expensive but also tedious due to strict ethical rules for animal experimentation. Fourth one is virtual reality. Virtual reality is in a laparoscopic surgery is a growing field, and lap mentor can be used for the to perform the various steps of surgical procedures. So to conclude my talk, laparoscopic suturing skill requires effective training and constant practice to perfect the technique. Adequate practice on simulation model shortens the learning curve, makes the trainee more confident of his skills, and improves the operative performance. Thank you.
Thank you, Dr. Mathur. Thank you very much.
Thank you.
I think any one of you have any comments and questions? I think the session is over, and we are on time. 11:50.
One small thing, I think Abhishek, you have put up, Abhishek and Naveed, I think both of them have put up a wonderful segment of pyeloplasty. Probably there's one thing which I thought I can add is one is a vascular hitch in a crossing vessel. So when should you be doing the vascular hitch in a crossing vessel? If anyone says, I wouldn't like to do that, I would do a pyeloplasty, he is well and good within his limits to do it. But the indications to do a vascular hitch in a crossing vessel is when there is only pelvic dilatation and when there is no calyceal dilatation. This has been very clearly put out from Imran Mushtaq from Great Ormond Street. So if there is calyceal dilatation with a crossing vessel, it is that we'll have to do a standard pyeloplasty. If there is no calyceal dilatation, you can think of doing a vascular hitch in these procedures. But anyway, thank you. Thank you all of you for the wonderful session.
Thank you. We thanks the chairpersons and we move on to the next session now.
Thank you very much, chairpersons and my co-convener, Dr. Naveen. Moving ahead with the theme of healing the healers, I call upon Dr. Zishan and Dr. Deepak Raguri to chair the next session.
Thank you, Abhishek. May now call our next speaker, Dr. Ranjan Shetty. He's a chief cardiologist at Manipal Hospital, Bangalore, a very young dynamic cardiologist, and he's quite known for his interventions. And he's joining us live via Zoom from Bangalore. Can we have the Zoom link on, please?
Dr. Ranjan, you need to start your video.
Hi. Hi, Zishan. Hello. Hi, are you all able to see me and hear me? One thumbs up from Zishan would be enough. Yeah.
Dr. Ranjan, we cannot hear you.
Hello. Okay. Okay. Yeah.
Yeah.
But now we can hear you.
You can hear. Okay. Okay. Thank you. And it's wonderful to be part of this team. Little, different from what we do. I'm happy to be part of Young Urology Association, and thanks Zishan for inviting me, and happy to be part of this. So my what we thought of discussing is love your heart. What's the time duration? I didn't ask that. Total talk is for is it 15 minutes?
Yes, yeah, 15 minutes.
Okay. So the what we see now, what we are going to discuss certain things. What we see, the whole country, if you look at country now, the life expectancy of the country is improved. If you see from independence to now to present era, I think it's now around 68 to 70 years. This is the median survival of the life expectancy at birth. So it becomes at 5 years it becomes a little more because the infant mortality is already down. But at the same time, the life expectancy of doctors has come down. It is 1 decade less than general public, and that is it's a paradox. The people who are supposed to save life are actually living lesser than the general public. So it's a paradox which we which is present, and it's a true paradox. These are not the made up number, and it's a true paradox. So why does it happen is something which all of us have to think and understand, and we'll have to talk about it. Now, the talk is not meant for elite group like you, but let me start with very basic. What is heart attack and what is cardiac arrest? Because this is what we keep hearing. Now, attack is when the artery ruptures and it's more like a plaque rupture and there is a sudden cessation of the blood flow. This person is still conscious. He's still talking to us, but he complains of chest pain. Typically what happens is when this happens, people want us to, want to do first aid, the common people. So what we advise them is don't do first aid if it's a heart attack. If the person is talking to you, if he has chest pain, then time is of essence. Make sure that they reach right place where a definitive treatment can be done rather than trying to giving aspirin or pantoprazole or, misdiagnosing it. So any chest pain has to be respected. A simple ECG done during pain is only 4% of heart attack. So whether it is doctor, whether it's common man, so if you have any symptom which is suggested, it could be gastritis, make sure you reach, because most of the time what we think is this time is lost and we lose a lot of people. The second topic is cardiac arrest. That means heart has stopped, person is unconscious and they're not breathing. Now, this is the real medical emergency. The bystander has to start CPR. It is nothing but a severe heart attack. If you see above 35 years of age, if people are, arresting suddenly, then it is nothing but severe. 80% of cardiac arrest are attributable to coronary artery disease, 80%. So above 35, somebody arrests, unless proved otherwise, it is nothing but severe heart attack. 1/3 of heart attack patients even today don't reach hospital. We cardiologists sometimes claim to have saved so many lives, but it's a myth. We only save people who are destined to be saved. That means we are saving only those who reach hospital. That itself tells us that the heart attack was not as severe as we thought, and they would have probably even without us survived. So it's important to understand and important to prevent. So that's one thing I think which is important. So if there is a cardiac arrest, that's what we should be discussing, because all doctors can manage the attack and they should come. But there is a huge neglect among doctors also as far as chest pain is concerned. Everybody thinks it is gas and dyspepsia and backache, and there's a lot of myth because the pain may not be very severe. It's not like the renal colic which you all see. I always tell our people, if the heart attack pain was like a colic pain, I think we wouldn't have missed any heart attacks because it's so severe and so devastating. But here the pain is much milder, it's more heaviness, and people think mild doesn't matter. So remember that SCA and SCA, sudden cardiac arrest, which leads to sudden cardiac death, is very important, and that's what we need to prevent. We all know this, we keep hearing about all this. It is no one is immune to this. We have had celebrities, great scientists, former president. APJ Abdul Kalam had people around him with gun to protect his life. But what he needs is, what probably he needed was a person who could do CPR, because he did have a sudden cardiac arrest. In all of them, invariably, it's the most severe form of heart attack. Unfortunately, heart attacks are like earthquake. You could have done a lot of tests the previous day. Imagine a person who has a heart attack today, and imagine for some reason I happen to do angio on him on the previous day, one day before heart attack. What would we find? We could find blocks which are more than 70%, but there is an equal probability that we could find blocks less than 50%. Person with a less than 50% block, say 10-20% block, may not present to us with any symptoms. They could be completely asymptomatic. They could have gone trekking, they could have climbed, even Everest for all you know, and it's possible that they didn't have any symptom. So being asymptomatic previous day does not prevent you from getting heart attack the next day. And just because somebody has 70-80% block doesn't mean putting a stent would prevent a heart attack. So this is a basic concept we should understand. If you have zero block, then it is okay. But even if you have 10%, 20% block, even such a patient with a severe emotional, physical stress, smoking, or for whatever reason, could actually suffer from heart attack. So this is a basic, when we talk about 70%, 80% people panic and they're always, thinking, oh my God, somebody, and one stent is put, they think that, our life is protected. It's not fully true. Even 70% can be managed medically, but it's the 10-20% which are worrying because they are in bigger number and they also could lead to heart attacks. So that's something which we should understand. Huge problem if it is a cardiac arrest, because that's what I'm sure most of us are interested in. Less than 10% survive. Though, when the person faints and falls, the syncope and arrest, death, the difference is the person with syncope gets up and the dead person obviously doesn't get up. So, but once he has fainted, we don't know which direction they go. So typically survival is only 7% in sudden cardiac arrest. But if you do a CPR, which could be a simple CPR done by anybody, it has to be a bystander, obviously, should be started within 2 minutes. And then the survival goes up to 33 to 34%, 33 to 34%. So for every minute that goes by, there is 10% increase in mortality. So average response time is 8 minutes. So what is the scope? More than 35 years, which I think you are young urologists. So I'm sure some of you are less than 35, but majority have read that. CAD is very, very common. And under 35, it could be HOCM, structurally normal heart, and things like that will be the problem. So these are different studies which show different prevalence. I think we shouldn't go too much to the numbers here, but we should start thinking how should we as doctors take care of our health. So how do we do that? So it's very important to have a healthy. So there is normal artery, there is minor disease in the artery, and even minor disease can lead to a heart attack. So what leads to atherosclerosis? In a simple term, it's modified cholesterol. I mean, it's cholesterol, but it's not that simple. It's actually active. It's actually dynamic. It's something which is there in the coronary artery and starts growing. This lipid which builds, even though it is 10 to 20%, the covering could rupture. So there is plaque, there is block. If the covering gets ruptured, then the clot could form on that. And that could lead to a sudden cardiac, heart attack, and it could be a sudden cardiac arrest. So what are the symptoms? Shortness of breath, sweating, nausea, dizziness, like typical symptom. And these are the MIs which occurs. So MI, all of us know, is the most dangerous thing. So let's talk about just preventing it. Preventing it is about healthy lifestyle. And healthy lifestyle has two components. One component is obviously diet. Second component is exercise. Diet, low carb. Nowadays, the concept is not low fat. It is low carbohydrate. Because cholesterol, which is the villain now, or which everybody thought a villain, is actually not dietary cholesterol. It is the blood cholesterol. So if you have high cholesterol in your blood, it is very likely because of a genetic reason in 90% of your cases. So whatever you eat, your body could convert into cholesterol. So don't advise people about low cholesterol diet, like red meat is okay, yellow, egg yellow is okay. Whatever oil you want to use, you could use. There is no need to go for special olive oils. Any oil is fine, obviously in limited quantity, but you need to reduce carb. Sugar is a new enemy. So carbohydrate has to be reduced. Sugar in pure form is reduced. Typical Indian meal, which has 90% carbohydrate, little rasam, little pickle, all that has to be avoided. It has to be 1/3, 1/3, 1/3. You should have 1/3, carb, 1/3 protein, and 1/3 fiber. So diet should be rich in fiber, okay in protein, okay in fat, but low carbohydrate. Next is exercise. Whenever people, we talk about exercise, everybody wants to run to gym and join membership, but equal number of people die in gym and while running marathon also. So exercise has to be graded. Exercise has to be careful. So when we talk about exercise, we are only talking about 20 to 30 minutes a day, maybe 4 days a week. This is something which all of us can do, and it's not too much, but this is probably where most doctors fail. So doctors probably, there must be years and months where you hardly do any exercise. So some exercise versus no exercise is important. So some exercise needs to be done on a regular basis. If you're doing a very brisk exercise, maybe, even 15 minutes a day for 3 days a week is enough, around 75 minutes a week. If you're doing a moderate exercise, around 150 minutes a week is what we need. So this is the kind of exercise which we are talking about, and this is something which we need to do. Extreme exercise, and if you're not trained yourself, could lead to a danger, because that's one of the reasons why the covering, the plaque, what we call as a plaque, could rupture, and that could lead to. So when you do exercise, it's important to do. It's very important to make sure that there is warm up, there's cool down. So if you're doing 30 minutes exercise, 10 minutes warm up, 10 minutes cool down is as important as 10 to 15 minutes of exercise. Again, I think this is where as doctors we fail, because when we want to do exercise, probably we want to build some muscle, but that doesn't help your heart health. It's important to have a balance. Maybe 1/3 of the time you could have cardio, you could build some muscle, but 2/3 you could actually do general exercise. Too much exercise and running marathon and doing extreme things without training is dangerous. So beyond 35 years, make sure you're not 20 any longer. So make sure, respect your age, make sure you do things in a right way and don't over push yourself. It's more about, making it's like a test match, not like a 2020. So make sure your targets are also, it's not friends marriage next week. That's not your target for health. Your target is when you are 50, when you are 60, you need to invest in your health, and it's not for short period. Now, what are the investigation? Everybody wants to get a health checkup done. So, people think that health checkup is like a service which you do to your car, that you go every year, every part is checked and you're certified. Probably not true when we talk about health. So it's important. Doing any test does not protect you from tomorrow's heart attack. It's the lifestyle, it's being healthy. If at all, if I have to suggest some test, yes, beyond 21 years, everybody should know their lipid profile. 1 in 250 have very high lipid profile, which needs to be treated immediately. Majority of Indians have some sort of dyslipidemia, which can be managed with healthy lifestyle, exercise, eating less carb. You could manage. So getting your lipid profile, I think, is something which is very important. Echo and TMT do not add too much value to your routine checkup, because as I said, TMT will be negative if it is block is less than 70%. But they could have heart attack next day. We have had patient who did TMT, negative TMT, went home in the car, had a heart attack during the car, and came back, a negative TMT, because the exercise itself triggered a MI in him. So any stress could trigger a MI. So if you've never done a TMT, don't jump and do it. So it's important because it doesn't pick up the minor disease, which are equally important for heart attack. Now, what do we do? CT angio, on the other hand, has a good role because it can pick up minor. It's not about you do CT, then get yourself get a stent. It's more about doing a CT, especially if you have family history, if you have borderline cholesterol or high cholesterol, if you have had some chest pain on and off, better to get a CT angio done. If a CT angio shows 0 calcium, 0 block, if you have these two 0, then next 5 year your heart attack risk is negligible. So it gives you a future prediction. Not many other tests don't do. So next 5 years, it's going to be negligible. And then after 5 years, if you repeat one more CT, and if that has 0 calcium, 0 block, the next 15 years, the risk will be negligible. So if at all, if you want to do a single test and if you're healthy, I think it will be a CT angiogram which needs to be done. Invasive angiogram is reserved only for symptomatic patients who have problem, because a stable disease stenting may not prevent MI, because that's the point. If at all you have to carry home, it's about treating with statin and treating with probably aspirin or clopidogrel most of the time. So if you are detected with a minor disease also, you need to take statin for life, and you probably need to take 1 antiplatelet per life. So CT angio, not for everybody, but among the tests, does have future predictive value. Diet, we already discussed, it's not about oil, it's about sugar. And dyslipidemia is something I think we could control the risk factors. People think they have been young throughout, they don't respect. So if somebody is hypertensive, make sure you control it. If you're diabetic, make sure you control it. It's this multiple risk factor which add together. See, people in generally, I think that's the, if there is a single risk factor, say BP is 200, everybody panics and everybody thinks there is a bigger risk. But it could be that 150 BP with diabetes, with smoking, with borderline cholesterol. So there are 4 risk factors which could increase the chance of heart attack by 8 to 10 fold. So remember to respect risk factors even when they are present in a, when they are in certain level. So it's important to understand and have healthy exercise is something which really helps. We already discussed it's 150 minutes per week, something which everybody can do. And obviously if there is somebody who is smoking, they should stop it completely, because even a single cigarette can produce heart attack, even though everything is normal, because even a 10% block can lead to. So here it's not dose dependent, even a single cigarette can do it. So that's something which is this. We always talk about stress. Yes, as doctors, we are stressed a lot, but we need to manage it. Stress is more endogenous than exogenous. That's something which you should understand. It's not the situation which puts you to stress. It is you who puts the situation in stress. So it's important to think about it all the time. Acute stress leads to acute problem like heart attack, like you see in movie, somebody dies, one more person dies. It does happen sometimes. And chronic stress lead to chronic disease like CAD and so many other disease. It's important to take regular breaks, maybe attend conferences like you're doing now, which is good. Also take some break, exercise, play a game, because it takes your mind off your work most of the time. Health checkups, as I discussed, it's overrated, but getting a lipid profile and getting your sugar, and some of us, although we are doctors, we may not have done our lipid profile for ages, and BP also, we only check for our patients. So it's important that we do this sometime ourselves. And that's how we manage risk. Don't overdo things. It is important. In a select few, there are roles for a lot of intervention, but the maximum benefit comes from lifestyle, because heart disease is lifestyle, and from drugs more than the intervention. I think I'll not talk about AEDs and all that. We'll be happy to take any questions if you have any. Yeah.
Thank you, Dr. Ranjan. That was a fantastic talk to highlight a few points, especially in this post-pandemic era. I think the stress levels have gone up and we're seeing sudden cardiac deaths, if I may say that. So do you want to highlight anything about this post-pandemic episodes of increased cardiac deaths, also in doctors especially?
Yes, that's a very, I think it's a very valid and a very important question. Yes, we have seen more problems post-COVID for multitude of reasons. COVID also is not a single disease as we think it is, because like say Alpha, which was the first one, the Delta, and now the Omicron have not behaved in the same time. Worst was Delta, because there was a huge magnitude of problem, and people, what we typically see is during the lockdown, during the high cases, the cardiac cases are actually lesser, but by 2 to 3 weeks, it starts picking up and it lasts for 3 to 4 months post. So that's what we saw in Delta. Fortunately, Omicron has been better, because it's become milder than flu most of the time. There are no inflammatory markers which are raised, and we are not seeing too many cardiac issues post Omicron. So so I think it's we should understand that COVID also has been not one disease, and it's important, like as doctors, as even the governments have to modulate their policy depending on what they find. But yes, if somebody has had COVID, they have to be a little more careful. They have to treat themselves as if they had a heart attack for some time. Don't rush into doing a lot of exercise. Always make sure you warm up, remember that it's all slow, it's all for long term.
Thank you. Thank you. I think we'll just take one question if there's anything from the audience. Anybody wants to comment or yes, Dr. Anil.
It was.
And the only thing which I would like to ask as urologist, BPH is a part of metabolic syndrome. And the cardiac patients and the bladder outlet obstruction patients quite commonly overlap in your, and we always see that we do angioplasty and patient goes into retention. And then the patient is on catheter for till the time the cardiologist permits us. So my point is that can we have, you had shown us the investigation profile. Can we add uroflowmetry in the workup on the ultrasound in the workup so that such a miserable situation does not come?
You're talking about post angioplasty retention, sir? Yeah.
Yes.
Okay. I think it makes sense, sir. I think it's more important to assess them. I think fortunately, I don't remember too many of our patients going through, post angioplasty retention. But yes, I think it makes sense. I think that key here will be taking a good history and understanding what is their pre-problem. But nowadays, I think the number of angioplasty done in a day is a huge number now across the country. But I think a history would make a perfect sense to me, sir. Taking this history, understanding whether they have any urological issues, it makes sense. And also, if I can add, I think both your and our patients are almost same. People with heart disease have prostatic issue. People with prostatic issue are high risk for heart disease to start with. I'm sure, as colleagues, we will have to interact with each other much, at many levels. Yeah.
Thank you, Dr. Ranjan. I think that was a fantastic talk and discussion as well. I thank you on behalf of Urological Society of India and YRU as well. Thank you for your time. And
thank you. Yes.
Thank you, Ranjan sir.
Yes.
And now
Thank you,
invite
session. Bye.
Dr. Aditya Prakash Sharma to begin the next session, which is a very interesting session. Aditya, over to you.
Hi, very good afternoon to all of you, and we'll quickly move on to the next session, which is on practice-changing publications in urology. I'll just brief you about it. We asked for young urologists less than 45 years of age to send out their publications, the original articles which was published in last 3 years. And I would take this opportunity to thank our blinded reviewers earlier, Dr. Gagan Prakash sir, Dr. Pankaj Maheshwari sir, he's there, and Dr. Abhishek Singh, who helped us out in narrowing down to these 8 amazing publications. So without much ado, I would like to invite the chairpersons for this session, Professor S.K. Singh sir, Dr. Anil Vashni sir, and Dr. Lakshman Prabhu sir. And meanwhile, we will start with the first speaker, Dr. Deepak Raguri sir. So the session is curated into 8 publications. It's 5 minutes with 2 minutes of discussion. Kindly stick to your time duration. There are points for that also. Thank you.
So just a small announcement
to
for
all of you,
benefit
young
of
people.
everybody.
Yes,
This is
normally
the
we
thing
use
that you have. This
the
is
youth
used
of
for forward slide.
USI.
This is used for backward
So
slide.
I am very much overwhelmed and privileged to be here with you, all of you. As a teacher, I feel if I can give you only a single point, I will feel quite privileged. And thank you very much for giving me chairmanship of a paper again on the research publication, which can change the practice. So the topic is very clear. All the presenter has to mind what the theme is. The theme is how your publication is going to change the practice. So that should be the theme. So that based on that, I think, I hope all of you will again dwell upon. What I feel, all papers are very good. All deserve to be awarded. But again, the managing committee, and they have decided that there can be only few limited awards. So therefore, judges has to mark the credentials of a paper. So therefore, as a chairperson, we have to help in restricting the time and then moderating the discussion and questions. I will request the audience, don't pass any adverse remarks or appreciable something which may not bias the judges, because just to be transparent. And at the same time, I will request all the presenter, please excuse us. Don't feel bitter of our questions, because we are here just to put some questions, not to slow you down, so that judges can decide whether the answer has been up to the mark or not. So this is the theme, and I feel again, I am very much thankful to you and Urological Society of India, as for all opportunities. Yes, all of us, we all. So yes, now we can start.
The first we had 4 minutes and 30 seconds.
Yeah, so first presentation is role of retrograde intrarenal surgery in managing diabetic papillary necrosis. And the presentation is by Dr. Deepak Raguri. And yes, Dr. Deepak is here. Your time starts now.
Thank you for the invite. I thank USI and YU for the opportunity, and I'm presenting my paper on role of retrograde intrarenal surgery in the management of diabetic renal papillary necrosis. Got published in Journal of Endourology recently. As we know, the diabetic mellitus is a non-communicable disease of epidemic proportions across the globe, and diabetics are 3 times more likely to get hospitalized with pyelonephritis. And renal papillary necrosis becomes one of the most important entity which results in obstructive uropathy, and then it is a very challenging entity to diagnose in the first place, because ultrasound is an entity which will not pick up this, nor a non-contrast CT. We would require a contrast-enhanced CT or an IVU to diagnose this. But that is with the risk of diabetic nephropathy or a decline in EGFR if you tend to use a contrast. However, these patients are the ones which land up with a retrograde pyelography and a DJ stenting. And what do we see? We definitely see a symptomatic improvement in these patients. And eventually we do a cystoscopy and a ureteroscopy to pull out these necrosed papillae, whether they are in the bladder or in the ureter. But after a dramatic recovery of these patients, the next question definitely remains is, what if there are necrosed papillae sitting in the pelvic calyceal system? Do we do a retrograde intrarenal surgery at all? Now that's where this whole paper comes into picture, and there is absolutely no literature for us to guide on. So the aim of our study was to pick up the role of RIRS in managing these necrosed papillae sitting in the PCS in diabetic patients. It was a retrospective analysis of a prospectively maintained database for these diabetic patients who presented to us with pyelonephritis or urosepsis and who eventually underwent RIRS during July 2016 to December 2020. The sample size was around 187 patients, and the study was approved by an internal committee, and informed consent was taken from all the patients. We included patients who are all diabetics, who presented with acute pyelonephritis, were not responsive to the initial management of IV antibiotics and antipyretics, and eventually landed up with an RGP-DJ stenting. However, we excluded patients with ureteric stones and renal stones, and ureteric strictures, obstruction in forms of extrinsic compression, malignancies, and of course, all the non-diabetic pyelonephritis patients. The other causes for your renal papillary necrosis, like analgesic abuse, sickle cell disease, CLDs, and tuberculosis, they were all excluded, however, from this study. These patients underwent an initial clinical assessment and routine laboratory investigations, including your ultrasound and non-contrast CT of KUB region. And they were treated appropriately with the antibiotics and antipyretics, and of course, a strict glycemic control. Patients who were not responsive for a period of the first 48 hours landed up with an RGP and DJ stenting. However, the presence or absence of hydrouretronephrosis was not a determining factor for these patients to undergo DJ stenting. The RGP findings were strictly noted. Renal replacement therapy, if required, was in form of a hemodialysis, and all these patients were followed up for the first 1 week to check on progression to renal abscess or fluid collection. And then all these patients eventually underwent RIRS after 3 weeks from the time of RGP stenting. All these patients underwent an RGP again once we found any filling defect in the PCS, and we went ahead and did a flexible ureteroscopy to retrieve these papillae from the PCS, and they were sent for histopathological examinations. However, we had 4 instances where the load of the papillae was so high that we had to do a percutaneous approach and pull them out, approximately 4 patients. And necrosed papillae, which were adherent to the calyx, were not handled at all because they tend to bleed. And if you look at the demographic data, the only things that I would like to highlight is that these patients were long-standing diabetics, approximately 12 to 13 years, and their baseline creatinine is 2.8 on an average. That justifies that we cannot give contrast in these patients. Poorly controlled diabetes, and of course, hemodialysis was required in patients approximately 22%. Another interesting finding is around 28 to 30% of the patients did not have hydronephrosis, and that was not a deciding factor to stent either. And if you carefully look at all this, just around 10% of the patients were in stage 1 and stage 2 of CKD. The rest of them are all above 3. So that also justifies our decision of not giving a contrast. However, the urine culture analysis, of course, showed that the positive cultures were seen in 63%. Of course, you had 36% of people with sterile urine also. And necrosed papillae was found in around 99 patients, that is around 53% of these patients. That's a significantly high number we need to take care. Post urinary diversion, of course, the EGFR continued to improve, but however, the follow-up of 6 months is not good enough. The only point that I would like to make in these instances is these necrosed papillae, when they sit in the PCS, tends to become a future nidus for infections, stones, and recurrent ureteric obstructions, and these have to be removed. The limitations of this study, however, is the lack of control group, a short follow-up of 6 months, and it's a bilateral disease, and we dealt with only in a symptomatic renal unit. And there is no available literature on this. A prospective multi-center comparative study with a long-term follow-up is the way forward. I would like to conclude saying these few points that we definitely believe that it has a role in the management of diabetic renal papillary necrosis. Thank you.
Any question from the audience? Otherwise, I have one question to you, Dr. Deepak.
Yes, sir.
You have got a sizable number of patients where there was no hydroureter necrosis, and you detected those patients who had papillae, right?
Yes, sir.
Now, why these people were not responding to the antibiotic, suitable antibiotic? One question. Secondly, so that's one question is. Secondly, my point is, yes, this is a retrospective analysis, and you have told the limitation, though the material methods are written in the way as if it is prospective. So I need your comment. One, without dilatation, why the patient was not responding, and you have to resort to intervention.
Yes.
Right.
Yes, I mean, papillae, absence of hydroureter nephrosis was never a decision-making entity for us to go ahead and do an RGP stenting. There was no clinical improvement with our routine IV antibiotics, which were chosen on the merit of our antibiogram of the institute. And in spite of them not responding clinically, not improving or deteriorating further, was good enough reason for us to go ahead and do an RGP stenting in spite of not having hydronephrosis. And sorry, sir, the second question was.
No, that was one.
Okay, fine.
Yeah. So Deepak, you did bilateral or it was unilateral?
No, so only on the presenting side, the renal unit where the patient had pain, loin pain.
Yeah, Deepak, don't you think that that cutoff of 48 hours is too early? Because conventionally, a large number of papillary necrosis are conservatively managed.
Yeah.
So what would be a recommendation? I would, since
unfortunately,
bring
yes,
it into practice, yeah.
48 to 72 hours is what a few papers have quoted on their initial response taken for the patients by IV antibiotics. However, we took it as 48 hours, and beyond that, after 48 hours, we went ahead and then did a DJ stenting, sir. That's the lack of literature I was trying to quote on. There are a lot of questions to be answered.
No comment, please.
No, so in the first place, when you remove the stent, maybe we should do an RGP there to see if there are any filling defects at all. So that once you find a filling defect, go ahead and pull out the necrosed papillae that are floating in the PCS. There is no other modality for us to say that whether there are necrosed papillae sitting in it. So that's the challenge here.
Thank you, Deepak. May we have Dr. Rahul here for the second presentation? Dr. Rahul Jana? Yeah. So patient renal and tumor attribute score, a comprehensive renal nephrometry score for use in patients, a comprehensive, with renal masses planned for minimally invasive nephron sparing site. Over to you, Rahul.
How do I change the slide? Okay. So can I just go back to the last? Yeah. So very good morning to my seniors and my colleagues. My presentation today is PRETA score. It's an in-house developed score at AIIMS Jodhpur for partial nephrectomy, minimally invasive partial nephrectomy. So this table shows a large number of renal scores. My observation is, if all these scores were so good, why would we feel the need to constantly develop new scores? And why would authors feel the need to combine two scores to form a supposedly a new novel score? So there are some things lacking in these which probably spur researchers like me to find newer scores. So these are the commonly used scores. On the left, you have the renal score. On the right, you have the Padua score. You go further ahead, you combine the two, remove some elements, you have the simplified Padua renal score, right? So all of these renal scores, nephrometry scores, actually tell you about the feasibility of doing a partial nephrectomy. And yes, they have been found to correlate with intra-op difficulty. Studies have shown correlation with trifecta and pentafecta outcomes. But are these nephrometry scores the only things which predict a complication? What about patient-related factors like chronic kidney disease? Studies have shown that people undergoing kidney disease kidney surgeries in the presence of chronic kidney disease have worse outcomes. What about when you are operating on a solitary kidney and something goes wrong? What about when you are operating on a kidney which has undergone some previous percutaneous procedure or some intervention? Is the surgery as simple in this kidney as it is in a native kidney with a tumor? So to examine all of these, we retrospectively evaluated the records of all patients of robotic assisted partial nephrectomy done in our institute. We noted the basic demographic features, the cross-sectional imaging characteristics. We had a dedicated radiologist who calculated the centrality index and the Mayo adhesive probability score according to the techniques described by the respective authors. So we found out that out of the total of 63 patients, 13 patients had a negative trifecta outcomes. And I am not showing the entire data for lack of time, but I am showing you the predictors of univariate analysis. The numbers in red, the TNM stage, the mean tumor size, the mean C index score, the minimum distance from the hilum, and the perirenal fat thickness, all of these were significant predictors of a negative trifecta outcome. And along with a Mayo adhesive probability score, creatinine clearance, that is a creatinine of less than 60 or presence of CKD, was a significant predictor of a negative trifecta outcome, along with congenital anomalies or previous surgeries of the kidney. On multivariate analysis, the factors which were significant on univariate analysis are further analyzed, and these were the factors we found to be significant. That is size of the tumor, C index score, MAP score, GFR less than 60, nearness to hilum, and congenital anomaly or prior surgery. So using these factors, we formulated the PRETA score like this. So, we graded them by giving them points. Size less than 4 centimeter on 1 and greater than 7 was 3. Similarly, the C index score greater than 1, meaning that it was a peripherally located mass, we got 1 point. And for less than 1, meaning that the center of the mass was very close to the hilar center of the kidney, we gave a score of 3. Similarly, presence of CKD, yes or no. Presence of congenital anomalies, yes or no. MAP score is basically that which tells you about the toxic perinephric fat. While doing minimally invasive nephrectomies, it creates a lot of trouble. So the score ranges from a minimum of 6 to a maximum of 15, and we graded them as per less than 6 is low risk, 7 to 10 is moderate risk, and greater than 11 is high risk. Going ahead, we did a prospective validation, but the numbers were less. We had only 15 patients, so we could not calculate any factors with statistical significance. But 6 patients had moderate risk PRETA score, of which 4 had negative trifecta outcomes. Now, the shortcomings were that it was a small sample size. It was a retrospective study. The prospective validation was done with a small sample size, and the use of C index and MAP score, it requires a trained radiologist and is time consuming, and it's a single center study. And also the redundant parameters that we removed from the previous renal score or the Padua scores, they were those scores which we thought were redundant. They haven't been proved in studies to be redundant by themselves. And this division that we did, that has also not been formulated into, it has not been validated. So
Dr. going Jena, ahead, your time is up. Please kindly speed up.
Going ahead, the similar score has been published in BJUI, where they have actually taken a lot of things like CKD, CAD, COPD, So what this score more or less does is it predicts complications that can happen with any surgery, not particular to partial nephrectomy. Our score is different because it predicts only the renal factors. In conclusion, our score predicts trifecta outcomes accurately, and by incorporating C index, we give greater objectivity for the endophytic, exophytic nature of the mass and nearness to the collecting system. It also takes into account patient factors which predict outcomes. Thank you.
Any one question from the audience, from the floor? One question, only one question, because time is not there.
Yeah, now I saw that in multivariate analysis, which you showed, you have assigned the points or parameters which you say, right? But all of these scores, all of the parameters, how come you could assign the same number of scores, right? For size, I think less than 4 centimeter, 4 to 7, more than 7.
Yes, that was according to the T staging. T, yeah.
How do you decide that whom to give 1 point, whom to give 2 points, whom to give 3 points?
Sir, I haven't actually shown that slides. We calculated the mean, the size of the tumors in our case. And when we are actually calculating statistics, we get a certain point beyond which the number of complications is more, you find a cutoff. I haven't been able to show those data because of lack of time, but we divided it into 4 to 7, more than 7 on the basis of the T staging of the tumor. Like T1 is, yes.
Okay, thank you, Rahul. With this, I invite next speaker and Dr. Rishi Nair. He's going to tell us about urethral instillation of povidone iodine reduces post-cystoscopy urinary tract infection in males, a randomized controlled trial. Dr. Rishi, please.
Thank you, Chairperson, sirs. Good morning, everyone. I'm going to present our publication on urethral instillation of povidone iodine into the urethra so as to prevent the post-cystoscopy UTI in males. Sorry, how do we progress this? Okay, sorry. So office cystoscopy is associated with UTI in at least 10 to 15% of the patients in various literature. And the general tendency is to prevent these UTI by increasing the amount of antibiotics that we prescribe to the patient, both pre-cystoscopy and even post-cystoscopy. So what is generally done in a standard part preparation in a cystoscopy is we just clean the abdomen below the umbilicus and the perineum till the mid-thigh level, and then start with the cystoscopy, instill the jelly into the urethra without realizing that the distal part of the urethra has bacterial flora in it residing in the urethra. So this bacterial flora can actually result in UTI post-cystoscopy. There is no literature available as to what is the role of this flora in causing the post-cystoscopy UTI. So to assess for that, we did this study. What we did was we isolated the urethral microflora in all the patients, in male patients that were undergoing cystoscopy. And additionally, we assessed whether the irrigation of this urethra, including the urethra in the part preparation with betadine irrigation, can actually reduce the rate of UTIs or not. We did a double-blind randomized control trial and included all healthy male patients, excluding all possibilities where some additional maneuver was done or the patient was predisposed to the development of UTI. All those sort of patients were excluded. The swab was taken at the time of cystoscopy itself. After doing the standard part preparation in all patients, we cleaned the glands with the saline and then took the urethral swab and then cultured it using the special culture materials and the methods. And then after that, we did randomize the patients. Half of the patients received this urethral irrigation with the 2% aqueous solution of the povidone iodine. 5 to 10 ml of betadine was used. So the sample size was calculated based on our own pilot study, and the 92 patients were required in each of the arm, keeping a power of 90% with a 5% alpha error. So this is the consort diagram. In both the groups ultimately had 96 patients. We were able to achieve our adequate sample size. And after the exclusions and all the follow-up, there were 96 patients in both the groups. We defined the development of UTI post-cystoscopy as any new genitourinary symptom, which was associated with significant bacteriuria after 48 hours of doing cystoscopy. All these patients had a pre-cystoscopy sterile urine culture. The standard urine culture was sterile. So these were the results. Baseline demographics were similar between the two groups. Both the groups had similar kind of predisposing factors or the factors which could result in development of UTI or sepsis, like diabetes, BPH, PVR, etc., were all equivalent in the two groups. So these were the main results. Only 4 cultures were sterile, which means that almost everybody has some organism residing in the urethra, in the distal urethra. All males do have it. There were some contaminants also. But the most common organism were the gram-positive cocci. The Staphylococcus and the Enterococcus were the most common. Though these do not generally cause UTI, but in the post-cystoscopy setting, they are known to cause epidermitis and epidermoorchitis. So these are also pathogenic organisms in that regard. The typical uropathogens, the gram-negative bacteria, were seen in about 15% of the patients. And these bacteria generally are the cause of developing UTI and sepsis. So overall, there were 28 UTIs that we had in this 192 patients. That is the 15% UTI rate. And most of the patients who developed the UTI after that, we were not, the swab was not corresponding. Although if gram-negative bacteria was grown on the swab, the propensity to develop UTI was about 45%. But not all patients who grew organisms on swab developed UTI. And this is the main result, that by irrigating the urethra with betadine 2% aqueous solution, we were able to reduce the rate of UTI by almost 1/3 with a very significant p-value. And even the febrile UTIs were reduced to a large extent. So to conclude, distal urethral commensal flora is present in almost all males. The urethral swab culture does not accurately predict post-cystoscopy UTI, but we can easily prevent these UTIs by including the urethral irrigation as the standard part preparation of the urethra, and we definitely recommend using it as a routine in office cystoscopy in all male patients. Thank you.
Dr. Rishi, I have 2 questions to you. One, are you practicing this in your institute after your paper got published or before you reach to after you reach to the conclusion? Second question to you is, was there any association with uropathogen grown from urethral swab and UTI bacteria grown from the urine culture if the patient became symptomatic?
Yes, sir. So we are using it. There was also concerns about the irritability of betadine in the urethra. So we have done a long-term follow-up study also with that, and we are in the we have sent the paper for publication of that also. There was no increased toxicity because of betadine. And regarding the second question, if gram-negative uropathogenic bacteria are there, the propensity to develop UTI is about 44% as compared to 15% in the overall group. So urethral swab culture positivity does predict the development of UTI, but it is only 1/3 of those patients who show a gram-negative bacteria, they ultimately develop UTI. So the correlation is not as good, but it is definitely.
Actually, doctor, you didn't follow my question. Question is, when you have shown the urine culture to be positive with Klebsiella and uropathogen isolated by E. coli, so there is no association. So did you see association between the urethral swab culture uropathogen with the actual bacteria grown in urine culture in symptomatic?
So that is what I'm saying.
28% had symptoms.
So out of 18 patients who grew E. coli on pre-op swab, 6 patients developed UTI because of E. coli only. So there is some correlation, but it is not absolute. So,
only one question. Yeah, please.
Irrigation is, sir, actually harmful because with the positive pressure irrigation and the trauma because of the rigid cystoscope, there would be micro trauma on the urethral mucosa. And with the positive pressure irrigation, it would actually lead to lymphatic and venous outflow, predisposing to sepsis. So it. Yes. So we have now completed, all patients are under follow-up. We have now completed about 2 years of follow-up in all patients. The good thing is that because all of these, most of
Thank
these
you,
patients
thank
were-
you, Dr. Rishi. Thank you very much. Thank
Post
you.
URBT, so therefore they are undergoing cystoscopy regularly.
Now we call upon Dr. Santosh. Then he will be presenting his paper on tamsulosin and placebo versus tamsulosin and tadalafil in male unitac symptoms.
Respected teachers, delegates, good afternoon to all of you. Thanks to USI and you for the opportunity. This paper was published in BJA in 2020. So why did we embark on the study? LUTS and ED are fairly common conditions which negatively impact quality of life. At the time we started the study, already tadalafil 5mg was proven to be the safe, low, most effective dose, and it was licensed as a monotherapy for LUTS. However, guidelines were based on evidence which were very heterogeneous for the combination. So both in terms of the drug used and the dose used, the data was very heterogeneous and the numbers were quite small. Even though tamsulosin was already shown to be the safest combination with the PDE5 inhibitor, also to the best of our knowledge at the time, there were no double-blinded RCTs with the intention to treat analysis. So we aimed to compare the efficacy and safety of tamsulosin alone with the combination with tadalafil 5mg in male LUTS. This was a prospective randomized double-blinded study after IRB and CTRI approval, and periodically the internal data safety monitoring board monitored the study. All men more than 45 years with moderate LUTS were included, while those with conditions such as prostate cancer and stricture were excluded, and also those who could not take the medications were excluded. The primary outcome was the International Prostate Symptom Score. The secondary outcomes included quality of life, the 5-point IAF, peak flow, and the PVR. The adverse events were monitored by passive surveillance of harms. So based on existing literature, the total sample size was 140, about 70 in each arm. Block randomization was used. Principal investigator and the subject were blinded. The blinding and allocation concealment was achieved by repacking the medications with a starch-based placebo and packing them in sealed covers. These were the statistical methods used. Imputation method was used for intention to treat analysis for the outcomes. So as you can see in the consort, in the group A, 71 patients were allocated, and in the experimental arm, 69 were allocated. After the loss to follow-up and discontinuation of treatment, 61 in the tamsulosin arm completed the study, while 55 in the experimental arm completed the study. All were included for the ITT analysis. These are the baseline characteristics. They were comparable. The mean baseline age was 60, around 60, and the baseline IPSS was around 15. The IAF was 10, and the Qmax was also around 10. As you can see the results, at 3 months follow-up, the combination group had an improvement in IPSS by about 5 points, and the difference in the improvement was in favor of the combination arm. Similarly, the improvement in quality of life, erectile function, and the peak flow rate favored the combination arm. There was no difference in the PVR. There were no serious adverse events. About 4 patients dropped out due to adverse events. The commonest adverse events was body pain, which was seen more in the combination arm. So ours was a double-blinded RCT with intention to treat analysis using a standard combination of tamsulosin and a 5 mg tadalafil dose. However, larger studies with longer follow-up may be needed to strengthen this evidence, even though some of the evidence has already shown that for the combination, the 3-month follow-up effect is maintained at 1 year. However, longer studies are required to confirm the profile. The study has been a part of a few meta-analyses. This shows one which shows a very low risk of bias across the domains. So to conclude, based on our study, the combination of tamsulosin and tadalafil is an option to improve lower urinary tract symptoms, quality of life, erectile function, and peak flow rate without significant increase in adverse events. Thank you.
question, Dr. Santosh, I think audience is not raising hand. I have one question to you. It's already in practice. How do you say your publication makes impact in practice changing?
So like I mentioned, sir, the evidence before that, the monotherapy was licensed, whereas for the combination, the existing data was based on very heterogeneous studies, both in terms of the PDE5 inhibitors used and the tadalafil dose. So one of the things we did was use tamsulosin and tadalafil 5 mg combination. And like I mentioned, the second thing was, to the best of our knowledge at that time, none of those were double-blinded RCTs with ITT analysis. Yeah. Okay, as far as the first question, our adverse events were followed up by just the passive reporting of harm. So between the groups, there was no difference. I think about 3% of patients had retrograde ejaculation, but that was patient reporting. It was not actively, we were not asking the question. That's the first one. Second one, I don't know the answer to that because in the study, we've used different drugs. We've not used a combination, even though some of the companies now come with combination. So I don't know the answer to that. I can't make that based on my study. Thank you.
Shall we have now Dr. Shantanu Tyagi? PBUS trial.
The topic is a single center prospective randomized study comparing functional anatomic outcomes after augmentation arthroplasty with penile skin graft versus buccal mucosa graft for anterior stricture disease.
A very
Yes,
healthy
Dr.
morning to all
Sam.
of you. It's my pleasure to be presenting this study in front of distinguished audience. The study is a PBUS trial. It's a single center study, prospective randomized, comparing functional and anatomic outcomes after augmentation urethroplasty with a penile skin or inner preputial graft versus buccal mucosa graft. A bit of a history. We presented our short-term outcomes at EAU 2019, and it was published in European Urology Supplements. A full trial in an abstract form was presented at AUA 2020, published in Journal of Urology. The complete study was published in World Journal of Urology in October 21. Latest by February 22, it has 646 article accesses. And on altimetry, it has an attention score of 5, which is more than 69th percentile and more than 74 percentile of the articles of the same age and source. This is an abstract. Our disclosures. Background, we all know that augmentation urethroplasty is a treatment of choice for non-obliterative long segment urethral strictures. We do have many options like locally available genital preputial skin, distal penile inguinal region. Distant mucosal sites can be taken like buccal, lingual, bladder, intestinal mucosa. Recently, tissue engineered templates are also used, but the published research and studies, they have till date failed to settle the issue of the best available graft. Most of the published researchers, they follow or they support the buccal mucosa graft, but the issue is they are retrospective studies. They do have inadequate sample size. There are few prospective studies, but they were non-randomized and unbalanced. But there is no level evidence till the time of this publication from an appropriate prospective randomized study on this subject. So our objective was to assess this surgical outcomes after augmentation urethroplasty. Our methods, it was a single tertiary care center parallel design randomized control trial with a non-inferiority methodology. PBUS stands for P for penile skin, buccal, BU for buccal mucosa, ST for substitution or augmentation urethroplasty. It gives a message that after this urethroplasty, you will P with a busting force. Allocation ratio was 1:1. The study protocol was approved by Institutional Ethics Committee. Participants were all the patients with anterior urethral strictures. Those were planned for augmentation urethroplasty. It was the settings and locations were OPD, Department of Urology. A study period was from 2018 January to January 2019. These were our eligibility criteria. All the strictures more than 2 centimeters in length and planned for augmentation urethroplasty were enrolled. And all those who have BXO, urethrocatinous fistula, scarred perineum, failed hypospadias repair, or unhealthy or unavailable buccal mucosa or preputial skin, those were excluded. Interventions, preoperative functional or subjective assessments were taken, IPSS, IAEF, MSHQ EGD, that is male sexual health questionnaire for ejaculatory function, and this is USS-PROM, urethral stricture surgery, patient-related outcome measures, which is a combination of LUTS domain, a peeling score. A Eurocall group has given a quality of life index for post-surgical cases. We try accessing, collaborating with them and getting a Hindi version of it. And it also comprised of a treatment satisfaction score. Preoperative anatomic and objective assessments were done with calibration of urethra, uroflowmetry, retrograde urethography, and voiding cystourethrogram. Intraoperatively, semi-raised retroscope was used for the assessment of urethral caliber and mucosa, and the dorsolateral onlay graft placement was performed for augmentation urethroplasty. Technique is well known, but usually it is thought that a long segment stricture, how can it be treated with preputial graft? So we have described a technique in which the length of the inner preputial graft can be bisected, and that can be used side to side, so that the longer graft can be used for longer stricture can be treated with this graft. This has also been published in World Journal of Urology, and we have recently presented it at a podium video presentation in recently concluded EAU. Interventions post-operatively, catheter was removed at 3 weeks. Primary outcomes were success rate at 18 months, which was either a maximum of a Qmax of more than 15, calibration of more than 16, or a repair which can traverse a 17-pin cystoscope. Important is the randomization. We use block randomization. Sequence generation was by a computer-generated generator. Allocation concealment was done by snooze. This was the consort diagram, eligibility of around 170 patients, and we randomized 48 and 47 patients into both arms. Baseline data was more or less comparable, and at 18 months, we have shown that there is no significant difference between the success rates. As an extension of it, we also proved it at 24 and 30 months with the Kaplan-Meier diagram showing the same thing. We also compared, sorry for this exhaustive diagram, but every parameter that we measured, it has shown the non-significant difference between the two techniques. The treatment-related emergent effects were also comparable. There were other studies compared to us, but none was a randomized study. Limitations was a short follow-up assessment at 18 months, and a stringent definition would have prevented a washout effect. A ventral only technique, we don't know how it works with preputials. Why is it presented there? Because it has a reproducible technique, familiar work field, learning curve is less, and depending upon the caseload, it can be mastered. Thank you.
Dr. Shantanu, the time is up.
Thank you.
Small time extending, yes. So one question we can permit for audience, otherwise I have one question. Yeah, I have one question to you, Dr. Shantanu. How do you think that this is going to change the practice? Because the theme of this session is practice changing publications. How do you think your paper is going to change the practice?
Yes, so this is the very first and only randomized trial which proves that both these graft materials, the buccal mucosa and inner preputial grafts, are equivalent. And inner preputial graft has its advantages that it can be done in a spinal anesthesia, same field, familiar to the urologist in COVID.
We have exceeded the time. Thank you very much, Dr. Shantanu. Thank you, because as a chairperson, we have to restrict and we have to be punctual. Thank you very much. Sorry for all interruptions. Yeah, we have to be disciplined, and we have to impart training to all of you that we have to be disciplined. Thank you. Now, Dr. Sudhir Kedimana from PGI Chandigarh. Yes, actually, initially they were asking us to judge. I told no, there's a conflict of interest. So whenever I'm hesitant when the paper comes from PGI, I should not put question to them. But same time, I'm the chairman, so I know my responsibility as a teacher, as an organization, but same time as a chairperson. Today, my duty here is as a chairperson. I've forgotten whether I'm from PGI, paper is from PGI or not. So now Dr. Sudhir Kumar Devana is associate professor at PGI. Please present your case.
Good afternoon all, respected chairpersons, dear delegates. At the outset, I want to thank USI and you for giving me an opportunity to present our original paper,
which was published in International Journal of Clinical Practice, which is titled The Development and Validation of a Novel Prediction Model for Predicting Renal Function Recovery Following Diversion in Patients with Obstructive Uropathy. As we all know that obstructive uropathy is one of the most common urological emergencies where early diversion is of utmost importance to preserve the renal function and prevent progression to CKD or ESRD. But the problem is there is scarcity of data available on the factors predicting renal function recovery. Particularly, I mean here the factors being the clinical and biochemical parameters which predict renal function recovery. These factors are not yet studied so far in the existing literature. And if we identify such factors, it would be of great clinical significance to the evaluating urologist and also to the patient so that we can counsel them better. So with this idea, we designed a score which is called the POW score, the PGMER obstructive uropathy score, by reviewing the literature and identifying the individual clinical and biochemical variables and then selecting them and considering, and we designed this score which included the age at presentation, the serum hemoglobin level, the duration of symptoms, presence of solitary functioning kidney, and also the venous blood pH. So a score of minimum from 0 to 7 was designed and the scoring was given like this. Subsequently, to validate this score, we have done a prospective observational study after institutional ethical approval, including all patients of obstructive uropathy presenting to emergency with a serum creatinine level of more than 2. And of course, as these patients are managed in the routine treatment guidelines, with specific inclusion include the blood tests, which included the hemogram, serum electrolytes, serum creatinine levels, and particularly the venous blood gas analysis, which pH was recorded. And subsequently, the patients were diverted by using the PCN or degestant or a peritoneal catheter in case of bladder obstruction patients. And they are monitored for the post-operative diuresis. And the fall in or the trend of serum creatinine, which changes over a period of time, is measured at 2 weeks and 4 weeks. So the renal function recovery was defined as those patients whose serum creatinine level dropped down to less than or equal to 1.5 mg per DL at the end of 4 weeks of diversion. So these are the statistical tests which are conducted. Specifically, I just want to point out the predictive ability of this score has been analyzed by using Yoden statistics, and also the goodness of fit model are also used to calibrate the model. The sample size is calculated based on Harrell's guidelines, where we come out to the sample size of around 50 patients in each group, both the recovery and non-recovery group. So during the study period, a total of 176 patients were enrolled with a median age of 52 years, and the urolithiasis being the most common etiology in these patients. So this is a busy slide where you can see the various clinical and biochemical parameters were analyzed using urea analysis, and of which we found that the age at presentation, duration of symptoms, serum creatinine level, serum urea, and the pH level in the blood, and serum hemoglobin level, presence of solitary functioning kidney, and the type of diversion and the need for dialysis, and then the final our score. All these factors have shown a significant predictor of renal function recovery. However, subsequently on multivariate analysis, we found out that the POW score, the overall score itself, has a independent predictor of renal function recovery in this analysis. And even we did the ROC analysis where we found that the overall POW score has shown the highest area under the curve. And then the calibration statistics are also favoring the score. Then we identified the cutoff value by keeping it at 5. We found that it has a sensitivity of 73.6% and a specificity of 83% in predicting renal function recovery. The basic strength of this paper is this is the only predictive score available to date in the literature on obstructive uropathy patients, which included the clinical and biochemical parameters for predicting the renal function recovery. And of course, it will help in prognostication of these patients as well. The limitation being the single center study, which has to be needing an external validation. And obviously, the renal function recovery is based on serum creatinine level, which can very well depend on the body mass and also the baseline creatinine level. So we conclude that the PGMER obstructive uropathy score is actually a simple score, which is yet accurate to predict renal function recovery in these patients of obstructive uropathy. Thank you.
So any question from the floor? One question permitted.
Dr. Abhishek Singh.
Dr. Sudhir, do we conclude that the percutaneous nephrostomy is a better drainage than double J stent because it showed some difference?
Yeah, that was seen when we analyzed it in univariate analysis. We found that definitely the type of diversion has a significant relevance. But however, when we considered it in multivariate analysis, it actually it didn't came out to be significant because of course, the initial sample calculation is based on the overall recovery. So, and these group of patients are quite a less number of patients compared to patients who were treated with DJ stent or the periurethral catheter placement.
Any other questions?
Okay. Thank you, Sudhir.
Thank you so much.
So with this, we invite Sumit is online, so we'll be taking him at the end. And this is Dr. Vivek Venkataramani, and he's going to tell us about predictors of recurrence and progression-free and overall survival following open versus robotic radical cystectomy analysis from the RAZOR trial with a 3-year follow-up. Dr. Vivek, please.
Thank you, sir. Good afternoon, everyone, and thanks to USI and YOU for this opportunity. So this was the study and a continuation of the RAZOR trial. And the RAZOR trial was, initially developed because there was really no multi-center prospective randomized study comparing robotic to open surgery in any organ site. And despite that, more than 4 million procedures had been done in 2017. So we did publish the original paper in Lancet in 2018. And I'll just focus on the results of the follow-up paper, which was published in Journal of Urology in 2020. So these were the 15 centers that were a part of the RAZOR trial. And the original trial had a non-inferiority design, and the primary endpoint of 2-year progression-free survival for robotic radical cystectomy was met. And it showed that it was not inferior to open cystectomy. So this paper focuses on overall survival, recurrences, and 3-year follow-up of PFS. So as I said, it was published in Journal of Urology in 2020. And this was our consort diagram. And for this study, we used the per protocol patients, 150 in the robotic group and 152 in the open arm. And disease recurrence was defined based on radiographic or pathologic evidence and RECIST criteria. And progression was defined as any recurrence or death from any cause. So statistically, cumulative recurrence rates were estimated using competing risk analysis with non-bladder cancer death as the competing risk event. This is a little bit of deep statistics that was required in order to show any significant predictors for recurrence. So these were some of the tests that we used. I'll not go much into the details. As expected, the baseline variables were well matched in both the groups, being a randomized trial. And at 3 years, the PFS again of both the groups was similar. 0.756 was the p-value. 3-year PFS in the robotic group was 68.4% versus 65.4 for the open radical cystectomy. Similarly, overall survival also slightly higher in the robotic group, 73.9 versus 68.5 for open, but not statistically significant. Recurrences, we analyzed different sites of recurrence to see if there was any difference and the numbers of recurrences. And again, both were similar in both the groups. So the important thing of this was that there was initially a lot of hesitation for adoption of robotic radical cystectomy because of risk of peritoneal carcinomatosis and things like that, which were supposed to be unusual patterns of recurrence, but that was not seen among our study and in many other follow-up studies. And the time to recurrence was actually better for robotic group, but it's very small numbers, so can't really comment. When we move on to the predictive factors, chemotherapy was not an important predictor of recurrence, but stage, surgical margin were obviously important predictive factors of recurrence. Similarly, for PFS, again, age, ECOG status, which affect the age in, which affect the health in general, and again, stage, margin status, and high Clavian complication rate of 3 and above. Those were more likely to also progress. And similarly, they also affected the overall survival. So basically, this gives you an idea of the predictive factors. And basically, robotic and open, there was no difference in terms of the recurrence, the progression, and the overall survival at 3 years. And the type of approach that has been used for the surgery was not predictive of any of these important oncologic outcomes. So this was one of the top 5 papers in the Journal of Urology in 2020. And we can conclude based on this evidence that this is a high quality level 1 evidence showing that robotic cystectomy is not inferior to open with respect to both 2-year and 3-year oncologic outcomes, which reinforces the safety of this approach, and it provides good data for patient counseling and discussion. So thank you very much for this opportunity to present this data.
To Dr. Venkat, any question from the, yes, there are 2 questions, yes, then I will.
So I have one question. Since it's a multi-centric study, did we compare surgeons, different surgeons might have operated this case, both robotic and open at the same center and at different centers. So did we look at this in this study?
So what was done was they were all expert surgeons who have had to have done at least 10 robotic and open in the previous year. So, and all academic centers. So baseline level was always good. Of course, there are institutional differences. So that was accounted in the statistics by using some frailty analysis. I don't really know the exact, mathematics involved, but it was accounted for in that.
Yeah. Yes, Dr. Abhishek.
The diversion in all the cases was left to surgeon's discretion, which could impact the outcomes.
Yeah, but they were well matched in both the groups. So that's all that matters.
Yeah,
and it was stratified
so
by that.
in continuity to that, Dr. Venkat,
yes, sir.
I have a question. That becomes very difficult to randomize the surgical procedure.
Yes, sir.
Because the people may not opt if you give the advantage of robot. So did you analyze the difficulty in randomization? Can you tell anything about that?
So in this study, luckily, there were a lot of, you are absolutely right. Generally, patients don't want to get randomized to one type of surgery or the other. And you could see that also in this study because a lot of sites had maybe 40, 50 cases, but some sites had only 2 cases, 5 cases. So obviously there was a discrepancy of the randomization in various sites. The convincing ability might be different of different.
You have reported that surgical margin is one of the criteria for recurrence and for follow-up.
Yes.
So now in robotic group, do you know that recurrence?
No, it's the same, sir.
Thank you very much. Thank you, Dr. Venkatamani. Thank you all. Thank you.
Dr. Vivek, just a question. Was there any center from India or Southeast Asia involved?
It's all US centers.
So is this data extrapolable to our subpopulation?
It is in term, if you look at the standard series of radical cystectomy, this matches in terms of T stage and age and things like that.
Okay.
So I guess it would be reproducible.
Yeah, quick question.
Sir, one quick question, sir, considering this was a per protocol analysis, not an intention to treat. So do you expect the results would have been different?
No, the intention to treat we did in the original paper, it was the same. So we just focused the follow-up on what had good data. So we didn't want to
Thank you, Dr.
include those.
Venkatamani. Thank you very much. Thank you. Now we can have.
So the next one is systemic dissemination of tumor cells during transurethral resection in patients with bladder tumor and its clinical relevance. It's a follow-up study by Dr. Sumit. It's an online presentation. Dr. Sumit, please.
Can you please share your screen?
Yeah, I'm trying to, sorry.
Dr. Sumit, this is a very odd time for you in USA. But yes, yeah, we are here to listen to you. I know that you're feeling drowsy, but we are very alert.
No, so I am also trying to be alert. It's just that I'm not able to share my screens. I'm sorry.
Thank you. Thank you very much.
Meanwhile, you share your screen. There's an announcement. There's an independent scoring going on for this session, and the winners will be announced at the dinner tonight, which is at Radisson Blue. And another announcement, we'll be serving lunch at 1 o'clock upstairs, and we have to be back by 1:20, 1:25 for the rigorous next sessions post lunch. Thank you.
What is the problem?
Actually, it's not allowing me to share the screen.
You want some assistance from us? Can
Presentation to us. Meanwhile, we finish one of our lectures and then we get the things sorted. Is that okay?
Yes, sir.
So
Aditya, we can go ahead.
So now we can invite, by the time Dr. Sumit Sen is going to be ready, we invite Dr. Bhavatej Engati to present USI collaborative research update. You know, this was the brainchild of the immediate past president, Dr. C. Mallikarjuna, to have a research of high quality in India. And we thought of, again, having audit as one of the ongoing project, where when we give audit, we can analyze what we are doing is wrong or right. Does it affect the outcome and how can we improvise upon that? So initially we were 4 senior people, quite old people. Then subsequently the young energetic people, he suggested 5 and all them are there. Dr. Bhavatej is going to tell you the update about the project and about the CRC to Dr. Bhavatej.
Thank you, chairpersons. Can I have my slides? It is not being displayed, please. Yeah, it's always a privilege to be part of the youth fraternity, and I thank Dr. Jishan for this opportunity. And it was a last minute slot which was available for us. I thank the committee of you. So I would be giving you the update of the CRC USI study group. As you are aware that this committee exists, majority of are participating in the studies which have been approved and going on. There are multiple institutes participating, but for who are not aware, it is actually CRC is a collaborative research committee of the USI. It came into picture in June 2021 under the guidance of Dr. Mallikarjun and the council of with the guidance of Dr. Keshamurthy. They have elected Dr. Nitin Tekre as the chairman, and we have formulated a core committee of 5 seniors and 5 juniors from all the respective zones. So far we had 2 approvals from the CRC USI study group. The first being the prostatectomy audit by Dr. Sujata Patwardhan. And initially we had a very slow pace. We were not able to pick up enrollments and many institutes were not participating. So we communicated, and Dr. Sujata and Dr. Amit, his co-investigator, had put in a lot of efforts. So we finally could get around 58 institutes participating in the study. The problem is, after the participation, we had another challenge that all the institutes who have participated were not enrolling their data time to time. So that is a big challenge for us. And so far we have the following respective institutes participating all over India. The second study was started in the April of 2022. That is on the perioperative antibiotic usage for endourology. This is under the principal investigator being Rishi Nair. It has been, I give a lot of credit to him, Dr. Rishi Nair, because he gave a 3-month run-in because it was approved in December 2021. We didn't start it. We had some hiccups in the first study. So we tried to do all the background work, and we started this study after getting approvals from all the other institutes participating for the IEC, and we started in April 2022. And now the enrollment is closed, and so far the effort is that since only 22 institutes have participated, we have a good data of around 1,300 odd patients. So this would be, we are making other efforts that to fill in the expected data in a couple of months, and we may good for data analysis. But the problem here we are facing is, are we progressing well? So the problem is, we have the caseload, we have a large number of institutes who have urology being as a DNB program or an MCH program. So far only 77 institutes have participated. There is a response of around 40 to 50%. Still we can do better. So this is one thing. We can also improve our patient care if we can have a multiple collaborative institutes collaborating in under one umbrella. And there are a lot of scope for having our own USI guidelines. So the only thing is, are we ready for doing multi-institute collaborative studies? So what do we do as a committee? Again, I would just we actually give support in planning research studies. You can present a protocol to us. We give you logistics supports. The USI has provided us an online data repository, which is free of cost for all the members. You can take this opportunity. And also we can plan multi-centric studies. We can use the online Zoom platform to communicate to all the institutes. So this has become more easy post-COVID. So this submission process is simple. You just need, like how you submit to your thesis protocol to your IEC, you just have to submit a small protocol to us. We recommend it to be a prospective study. It should be a short time span, because we know that there is an enthusiasm initially, but over a period of time, if you have a long follow-ups, we have a lacuna in assembling the data or entry of data. The CRC will approve this protocol. If there are some revisions, we will make sure that it can be done. And once the approval is done, the principal investigator gets the approval from the IEC, and the following process goes on. And the principal investigator, with the help of USI, will publish this in the newsletter. You can, under the banner of CRC, can send it to your WhatsApp groups. Like-minded people can collaborate, and the co-investigator has to submit the basic ideas. So based on this, we have a separate online data repository, which is very secure. And we have made a website based on this, which is apart from the USI website. This is a different portal which we need to give access to all the members who are participating. So far, the website, all the details of this online data repository is available in the USA website. You can visit the announcement section. All the details of the submission protocol, guidelines, everything is available. Yesterday, we have got the portal, online portal also live, but we are just waiting for the council decision to integrate it to the website, so that we have the projects, we get a live feed of how many patients are being enrolled in the study and how many institutes are participating. This is a weekly update which we can do. So this is how the data looks, and this is how the data can be entered. This is all a different platform, which is a secure system. So I would say that the USI subspecialty is a blessing in disguise. Now, I know it is a big challenge. It was a big challenge for the USI to make subspecialty sections. I know it gives a revenue for the USI, or it gives recognition. Just go back to the one slide of, this is one movie which has been released pan-India, most of you are aware. Like this, USI subspecialties have become a revenue process. It is a process where there is recognition for individual members in each subspecialty, and hopefully there was some revolt, but now hopefully this research can be helpful for the CRC USI. So I would conclude that you can be a platform for the future. You is a platform for the future. You can send us the protocols, and even if you wish to collaborate with us, we will facilitate. So CRC USI is there for you to guide in all the research platform. Thank you.
Yeah, thank you both. I think to young people, actually, the idea was of this presentation was just to stimulate you. The senior people like us, we are here to help you, provided you ask for help. We are forcing on you, and we are pressing hard on all of you. Please come forward, we can help you. We have spent whole life for all these activity. We want to hand it over to the young people. And Dr. Bhavtej has been backbone of this, I must say, because every time he is again pursuing the things. Today morning, I got a message from him on the WhatsApp. Kindly see it. Please give your comment. So that's the way young people should go on doing. And we will feel proud of you, because we want young people to fly high and to give make us feel proud of all of you. Thank you very much. Thank you, Dr. Bhavtej.
Thank you, sir.
Very much. Dr. Sumit.
Good morning, sir.
Yeah, thank you very much. Yeah. Over to you, Dr. Sumit. Yeah.
Okay. Good morning to all honorable chairpersons and distinguished delegates, my seniors and my colleagues. Thanks a lot for giving me this opportunity to speak about my study, which was published in Urologic Oncology, which is a journal of Society of Urologic Oncology. And it was published in February 2021. The title is Systemic Dissemination of Tumor Cells During Transurethral Resection in Patients with Bladder Tumor and its Clinical Relevance, a Follow-up Study. So as we know that transurethral resection is the standard procedure for diagnosis of bladder cancer. It is sufficient surgical treatment for non-muscle invasive bladder cancer when complete resection is done. But it is done with piecemeal resection of the tumor, which refutes the standard oncological principles. So, and the tumor cells are shed and considered one of the potential reasons for recurrences by the intravesical seeding, and that is the basis for the intravesical therapy. There are chances of tumor cell seeding into circulation due to the high intravesical pressure and cutting through the tumor. What's known is that the flow of fluid into the open vascular channels or as a transudate into the third space does occurs, and the tumor cells may move along this fluid. So this concern has long been feared but never conclusively proven. So the primary objective of our study to see whether the TURBT can cause hematogenous dissemination of the cancer cells or not. And the secondary objective was to study the correlation of these tumor cells with histopathology of the TURBT specimen on the basis of grade, stage, and oncological outcomes. So we included all the patients with primary presentation of their bladder tumor and with resection time of at least 20 minutes. We excluded all patients who had history of previous TURBT or in whom only biopsy was taken. We also excluded patients with prior radiation therapy, prior intravesical therapy, metastatic disease as presentation, and having variant histology. The study was approved by Institute Ethics Committee at AIIMS, New Delhi. The standard protocol we followed, we resected all tumors in normal saline using bipolar current. Fluid bag was kept at 60 centimeters above the bladder, and 10 ml of blood sample was collected both pre-operatively and within 2 hours of TURBT from the peripheral veins. And those the blood samples were evaluated using flow cytometry. So the study was done in collaboration with the Department of Biochemistry. We validated our method for detecting the circulating tumor cells by spiking the blood samples of healthy volunteers with known number of T24 bladder cancer cell lines, and our method was able to detect almost 95% of the cancer cells. So then we use the same method in the patients, and to be considered as a CTC, there should not be any expression of CD45, and it should be positive for cytokeratin 18, 19, and EpCAM. We use the gating strategy for detecting the tumor's number, the circulating tumor cells number. So in the results, in total of 53 patients were included, majority of them were male. Endoscopic complete resections were done till the level of deep muscles. No perforations were encountered. Out of the 53 patients, 9 patients showed increase in the circulating tumor cells after TURBT, including 3 patients in whom CTCs were demonstrated even prior to TURBT. In total, 17 patients had a muscle invasive bladder carcinoma, and out of which 9 patients were found to have circulating tumor cells. Now, as we can see from this table, 9 patients are having CTCs, and in total, 17 patients were having muscle invasive bladder carcinoma. This is the chart of 9 patients, and we can see in this 5 patients were having node positive disease in the eventual histopathology after radical cystectomy. Out of these, 3 patients were having CTCs even prior to TURBT, whereas in rest of the patients, TURBT were found only after, circulating tumor cells were found only after TURBT. We also studied the impact of resection time, that whether the resection time does have an impact on dissemination of those tumor cells. We found no significant impact of the resection time, when comparison is done between the non-muscle invasive versus muscle invasive bladder cancer, and in the subgroup of patients with muscle invasive bladder cancer in whom the CTCs were found before or after the TURBT. When we analyzed in the subgroup of patients with muscle invasive bladder carcinoma, in patients having CTCs and not having CTCs, we found no significant difference whether they received cystectomy, stage, node status, the status of their chemotherapy, but we did found recurrences, and the recurrences were almost equal in both the groups. We did the follow-up for 24 months, and out of these 9 patients, 6 patients were found to have CTC only following TURBT. 3 of these 6 patients developed recurrences on follow-up. We found that risk of recurrence was 18% higher in patients showing a measurable rise in CTC following TURBT, and the risk increases to 33% after excluding the 3 patients with measurable CTCs before TURBT. So our study is one of the preliminary studies in the world literature. Our findings confirm the hypothesis that cancer cells are inadvertently infused into the blood circulation during TURBT. So there could be a potential role of piecemeal resection, higher intravesical pressure.
Dr. Sumit, I think we are running out of time. We just gave you 5 minutes. We have to forcibly stop you here. There's one question, how this study is going to change the practice. Could you answer that?
Okay, so as we know that the TURBT is one of the most common endourological procedure. It's not a groundbreaking study, but it does it's an eye-opening study because it establishes the safety of TURBT non-muscle invasive bladder cancer, but it has a potential to cause dissemination in muscle invasive bladder carcinoma. So we have to avoid overzealous resection in those patients, and only biopsy should be taken if it seems that it's a muscle invasive bladder carcinoma.
Thank you. Thank you for taking your time. I know it's too early for you.
So with this, we invite, thank you, dear.
Okay, sir.
And with this, we invite Dr. Aditya Prakash Sharma, and he is going to tell us increasing the visibility of your publication. What should you know? So
I know you are the convener of this session, but same time you have authorized us to limit the time. We request you if you can minimize the time so that punctuality.
Learning can be improved. Indian initiative recently in 2022, we have JGate, we have other resources which you can use to access literature which is available globally. Regarding global access to Indian research, the key challenge is how do we reciprocate the information flow and improve visibility and impact of Indian research. At institutional level, there are repositories at All India Institute of Medical Sciences, PGIMR, we have our own digital repositories which are open access and make our paper more visible. The first and foremost important thing is to do a quality work. If you have done a quality work, you can sit back and that will get recognition itself. These are few research tools which we are routinely using, and they are also helping us in making our research more robust so that it can be making more citation and more visibilities like Web of Science, Scopus, EndNote, and such targeting suitable journals, because a question poses that this is an article I have curated and I need to publish in which journal. So these are the journal citation reports, journal metrics, Chimago, you can use and go to where you can choose an appropriate journal for your article. This is a core slide which I would like you to take home. We move on x-axis from informal to formal mode of scientific communication, while vis-a-vis a private closed communication to an open communication. So we have papers and books which we all used to go through. We are going through now in this era of internet. We are more and more going into a social media kind of things. Talks and posters, communication in meetings like this is kind of an open dialogue in which we have one-to-one interaction. There are conversation emails in which one-to-one you can have an interaction with your peer groups, in maybe in your faculty groups, in our resident groups, you can do that. We have preprints. I will just briefly touch upon. We are very afraid of preprints, and we are thinking about that the data can be poached, the idea can be poached in preprints, but that is not the order of the day. Social media, we are all aware of, but whether it is increasing citation, altmetrics indices, I'll just tell you briefly. Blogs, these are the oldest method, almost a decade old, but whether they can help us out or not in a true sense is to be seen. First and foremost, to increase visibility is the open access publishing. Now, IJU is open access, SIU General is open access. You have all major journals going into open access, but the hindrance there is the article processing charges, which deter us from publishing in these journals. However, if you look at the open access citation rate is much better as compared to the closed access citations. These are few of the other research groups available in which you can have access to the databases. Benefits of open access publishing are widespread. There is a wider dissemination of research. There's greater impact, faster publication for authors. For readers, it's a barrier-free access. We are also looking at Sci-Hub and what all in form of Hinari. We are searching those for a free access publication. If it's an open access publication, it's easily available and visible. For libraries, it solves pricing and permission crisis. And this was a meme which was circulating that there is a growing inaccessibility of science, which was published in Nature, available for $199 subscription. So what you should know about pseudo general and open access publishing, don't get carried away. That is the key home messages. We just recently published that pub coins, which we are all interested in collecting, such as Bitcoins, are important, but not as the cost of your professional or the author integrity or scientific integrity. So you can go through this to understand the nuances of open access publishing. You can use the reference and citation enhanced in-text databases, which include Google Scholar, which will make your research more visible, and it simplifies your CV creation. You can use ResearchGate. These are useful indices, not only for recording your citation, H-index and I-10 indices, but it can also tell you that you have a long way to go. You can look at your mentors, the quality of research and the amount of citation Professor Singh has. You have a roadmap to go to. Blogs in clinical practice, I am personally not using, but it's the oldest form available. You can have a dialogue. You can put your research out there. You can get comments from others, your peer reviews, even from in a public domain. One very important thing which we learned from Dr. Bhavtej also, we need to increase collaboration. There has to be multi-centric collaboration, international collaborations, which is going to make you more visible. Approaches to collaboration will differ between the discipline collaboration you can do, which will, because the certain medical specialties have a higher citation rate, better journals in which you can publish by collaborating with them. These are unique research ideas. You should create them and you should use them whenever you are publishing or you are submitting a article to any journal, because this will automatically link those articles to your profile and this will make it much more visible. Preprints, we are all afraid to use preprints. These are the website which will allow you to freely update your publication into it. This is not peer reviewed, but you'll get a DOI and you'll get the credit of your publication. Even if you are publishing in a journal which is closed access group, you can keep your paper as a preprint. You get a valuable feedback, you can improve. It's kind of a peer review process. It's increased the visibility, and this is from JAMA. It says that altmetric score citations improve if you are going for a preprint and then you are publishing in a journal. Increasing outreach using social media. Everybody is on social media. Twitter is full of youth conclave now. It's almost full today if you look at Twitter. So you can use these websites. Even if you look at the journals mails which they give you, they give you a 50-day free access in which you can share your articles in Facebook, Twitter, LinkedIn, Mendeley and whatnot, so that your article is more visible. You can use visual abstracts so that it can give you an impression to the normal public. They don't have time. We don't have time nowadays, but the visual abstract is a very good way of presenting and showing your data on social media. So just an example, this was a meta-analysis we recently published. I tweeted it. It got eyeballs and it was published in a medical dialogue. So it's not only the social media, you can also get into a public domain, or the conventional media can get a eye catch of those, and it can have an impact. Like this was picked up by medical dialogues and was shown to the general public like this. So whether it actually increases citations, definitely yes. Twitter, if you are using it, has shown that it has 2-fold more Scopus citations and 2.3-fold more Google citations if you are compared to the articles with no Twitter mentions. So I will ask you to use more of social media, not at the cost of your time, definitely, but use it for making more visible. In a nutshell, first and foremost, you need to have a quality work. choose a relevant topic, a topic which is currently valid, practice changing, increase your collaborations, use keywords which are matching to your title, use a title without your institution or a country name, open access, you carefully use those. APCs again become a challenging thing. Actively promote, even if you are in conversation, discuss about those, present at conferences, and use social media for making an impact. Thank you so much for your patient hearing, sir.
Thank you, Dr. Aditya. Really, you have told, yes, when you have worked, you have done some publication, let the people know it so that they can use it. They can put it to advantage. Thank you all. Now, I am very happy to again apprise the audience that this is the first time this session has been included by the young people, youth of USI, our members, young member, and there have been 34 research publication papers were presented for competition. The practice changing publications. So there were 34 submission, and these all papers were scrutinized by 3 scientists and urologists of the country. And then ultimately, because there was limitation of time, so only 8 papers, depending on their score, were selected for presentation here. I really appreciate all of them who has submitted their paper for presentation for this session. And don't get discouraged, because maybe in the future, we'll see how the things can be again accommodated when there are something more. So thank you very much. Thank you all for your patience hearing. Thank you all. Thank you all. I will not like to name the people who has scrutinized the paper. They have taken a lot of pain, but for matter of confidentiality, I have not to tell all of you. Thank you very much. Have a nice day and have a good football session.
So we are having lunch at a floor above, and we will come back here at 1:30 sharp for the next session, which is uro-oncology. See you all at lunch.
Beauty.